juniors
ma'am.
and
We are not
friends.
live now. 1 second, ma'am. We are not
Okay,
live now.
okay.
Sorry.
Okay, let me also check whether more people are going to log in. अंकुर तुम दिख रहे हो?
Yes, ma'am. We are live now.
Sneha ma'am, should we start or should we wait for Dr. Kinkot?
No, go ahead. We should.
And Malhotra sir and ma'am.
Hi Nutan and hi Dr. Pragati Bharti here.
Hello, Bharti ma'am.
evening.
Welcome.
Please start by the time.
Yeah. Very good evening. Okay. Finally the recording has been started. Should I start now?
Yes, ma'am.
Right. A very good evening and बहुत ही प्यारा namaste to all our esteemed guests here and the presidents and secretaries of all societies, respected speakers, Dr. Mullidhar Pai sir and Dr. Bharti Maheshwari, our very own Dr. Bharti Maheshwari, and also a warm welcome to Dr. Rakhi Singh also. A very warm welcome to Saroj Singh ma'am. Namaste. And with greetings to all of you. I would like to start this 50th episode of AMOGs Societies this webinar series, which has been with we have this is the second season that we are doing with UPCOG, and slowly all our societies have been involved and interacted, and we have had a very interactive and learning session under the dynamic academician Dr. Sneha Buhar, who is a very keen academician. So we will start a program with invoking the blessings of Ma Saraswati. Can we start with the lamp lighting, please?
Presence of an expert gynecologist, obstetrician.
So I am Dr. Nutan Upadhyay, and with me is Dr. Pragati Agarwal. Both of us are so glad to be associated with Dr. Sneha Buhar, and we are together going to welcome you all for this academic webinar. And I would now like to welcome Dr. Sneha Buhar ma'am to introduce our guest of honors and chief guest. I think ma'am is on the phone trying to contact her. By that time, I'll take this opportunity to welcome. Yes, Dr. Jaideep ma'am is here. Namaskar, Jaideep ma'am, and a very warm welcome to you. Namaste ma'am, namaste.
Hi.
Swagat hai ma'am, swagat hai.
Hi Nutan.
Hello ma'am. And I think
Namaste Jaideep madam and welcome from UPCOG.
Namaste.
Yeah, namaste Bharti.
Yeah. Madam, good evening.
Welcome.
Good evening everyone.
Good evening, ma'am.
Right. Now, so I would like to invite our dear Dr. Sneha Buhar to invite our chief guests and guests of honor, and also to remember our dear patrons also. Dr. Sneha Buhar.
Yes. So a very good evening to one and all. My respect and regards to all the seniors present here. At the outset, I would like to thank Team AMOGs as well as UPCOG for giving us this opportunity. I would like to thank the entire team of UPCOG, the office bearers of AMOGs as well as UPCOG, Dr. Kiran Kurtakoti, Dr. Bipin Pandit, and of course, Dr. Madhuri Mehndar and Dr. Pardesi. And from UP side, our chief patron, Madam Usha Sharma, the office bearers, I would like to acknowledge and thank all of them. Madam Usha Sharma is right now in the car going back from hospital. So, Madam may not be able to join.
जैसे हम और आरसीए की प्लेटफॉर्म पे आ गए ना, हम बच सकते थे इससे, बट अब कोई बात नहीं। अब
Bharti,
यूपीसीओजी की सेक्रेटरी के नाते मुझे बुला लेना।
Bharti, can we request you to mute yourself, please? So, at the outset, I would like to thank all of you to grace this program and bless me in particular. I would like to welcome, actually, it was my pleasure to welcome Madam Usha Sharma and have her blessings, but Madam is just convinced not be able to join. So, I would like to invite Professor Dr. Narendra Malhotra and Madam Jaideep Malhotra as chief guest for today's program. I'm very thankful to all of you for accepting the invitations, and of course, I would like to welcome all the speakers, especially Dr. Murlidhar Paisar, Dr. Bharati Maheshwari, our dear friend, and of course the chief guest and guest of honor, Madam Sadhna Gupta, Dr. Saroj Singh, and Dr. Rakhi Singh. I would like to welcome all the conveners, Dr. Nutan, and of course Pragati, and all the chairpersons,
Hello.
esteemed panelists.
Hello.
Yes, madam.
Hello.
So very
Okay.
happy to have you, madam. Thank you for joining. Over to
Sneha,
you for your
I'm so
blessings, madam.
sorry. I'm with my daughter and just packed up everything coming back from Apollo to the house. And I'm sure this event will be very, very good and will be very beneficial for all the persons who are joining it. And you have always tried to uplift and organize such webinars along with UPCOG and AMOGs. I wish you all the success. Thank you very much. Sneha, just only I was not able to just log in, but then I thought that as you are upset about it, so I just made it that I could
Thank you.
join here. So
Thank you,
thank you very much and wish you all the best. I'm sure that today, whatever topics and whatever discussions and panel discussion you will have will go a long way in updating the knowledge of each one who are attending this. Thank you very much. Once again, wish you all the best. Thank you very
madam.
much.
Thank
Thank
you.
you,
Okay.
ma'am.
Thank
And
you,
on
madam.
my
Thank you so
behalf,
much
on
for your
my
blessings.
behalf, you have Narendra, Jaideep, Bharti Maheshwari, Secretary, and Saroj Singh. You have got our President and Secretary UPCOG with us, with
Yes,
you, as well as the advisors, Dr. Narendra and Jaideep. So I'm sure this will be very, very beneficial for everyone. Thank
yes.
you very much, Sneha.
Thank you,
God
madam.
bless you. God bless
Special
you.
thanks to you for joining, you know.
Dhanyavad, ma'am. Welcome.
Thank you. Thank you so much.
Okay, okay, Nutan. All the best.
Thank you, ma'am.
Thank you, madam. So
Okay, Pragati. Okay, okay,
Thank you,
bye.
madam. Thank
Bye,
you,
bye,
madam.
bye.
I would just like to welcome and thank all the president and secretaries from the Agra Society, Dr. Richa Singh, Nidhi Bansal, Dr. Deepali Verma, Dr. Neha Bansal, from Muradabad, Dr. Noida, Dr. Rakhi Singh and Dr. Anika Saxena from Noida, and of course from Hapur, Dr. Anjana Saxena, Dr. Renu Bansal, Dr. Sadhna Jaiswal, and Dr. Samta Gupta from Greater Noida. Dr. Kalpana Dikshit and Dr. Reshma Nigam from Kanpur, and of course our two Maharashtra societies, Yavatmal, my own society, Dr. Archana Rathod, Dr. Sheetal Chavan, and Dr. Rajendra Chavan and Dr. Rajendra Tiwari from Palghar Society. I would like to welcome all of you, and I just take this opportunity to invite and welcome my mentor, Dr. Narendra Malhotra and Dr. Jaideep Malhotra, madam as well. So can we have Sir CV first? Prerak? All of you know, sir, you know, he's the past president of Foxy as well as the ISPAT, and he's the director of Rainbow IVF Center. I'm sure all of you know him. I can't read this the CV, which is, you know, so highly decorated and such an illustrious personality he is. I'm very happy and proud to have him as mentor. So can we have Sir's precious words first? Do we have Sir joined? No, I think Sir has not joined. So we can have Madam CV and Madam speech first. Prerak, can we have Dr. Jaideep Malhotra's CV? So Professor Jaideep Malhotra, Managing Director of ART Rainbow IVF Center, and of course, past president of Foxy, ISPAT, president-elect, and past president of Aspire. Just in the organization, and she has headed it. That much I can describe Madam as, and a very loving and caring person and a great mentor to have. Madam, over to you for your precious words, Madam.
Thank you
Welcome.
so much, Sneha. Thank you, and a very good evening to all of you. It's a proud privilege for me to be here today. I would like to wish all of you first a really happy World Environment Day today. And it's really important because today, on this particular day, we are discussing a lot of things where directly environment is also having its role to play. So let me really congratulate AMOGs, Sneha, and all the societies which have joined today. It is really important that we understand what we are really discussing. And I saw that you have some wonderful speakers today. I really adored Murli as we had visited Manipal for number of years. And Murli, thank you for being there. And it's nice to see you on the screen.
Thank you. Thank you,
Hopefully, we'll
Renu
meet you
Devi.
someday, in person. Of course,
Sure.
Bharti again, and Sneha. All three of you are going to really do justice to whatever we are discussing. Yes, fetal growth retardation. Today, in fact, I was just making some video for someone today, and we were just trying to see why we are the way we are, and growth retardation, and so much environment has such a big role to play. And if we are able to connect all the dots together and get the right message, and change our practices, our thought processes, I'm sure it will be a win-win situation. So apart from the medical and the academics which we discuss, I think an overall picture of connecting the dots on what is affecting the outcomes of our pregnancies and our babies and the health, all of us, our health, are very, very important. And I'm sure all the speakers are going to do justice to it. And I'm really looking forward. All the best to all of you. And Sneha and Bharti, all the best for your future endeavors too. Thank you for having me here. It's
Thank you.
really a proud privilege. Thank you.
Thank you, Madam.
Thank you, Jet.
Thank you so much for your precious words and, of course, that warm wishes from you always. Over to you, Dr. Nutan, for further proceedings. Sir is joining in a minute. We can have
Yes.
by the time.
By the time I would take this opportunity to invite Dr. Saroj Singh ma'am, the president of UPCOG, and a very hard-working secretary of UPCOG, Dr. Bharti Maheshwari. Both of them have been backbone of UPCOG, and they have literally taken the society ahead with all their hard work. Saroj Singh ma'am, please, your words of enlightenment.
Thank you so much, Nutan. Thank you, Sneha, for making me a part of this prestigious webinar. And it's a great pleasure to see that both UP and AMOGS are joining together in these academic sessions. It becomes very useful that when academic is going on, there are many people who understand and then go take it in clinical practice. So lots of congratulations for doing this joint activity. From UPCOG, we have also listened the blessings from our respected Usha Sharma ma'am and our advisor, great advisor, Dr. Jaydeep is here. Dr. Naren is just going to come. We have this power couple with us to guide us, to show us path in many ways. So, and the UPCOG with Bharti Sadhna as vice president, we have so many good working hands, but in this AMOGS is also doing very well, Sneha, and especially it will be a feast for us to listen Dr. Murlidhar, because we have listened many of his lectures on online or offline, but it's very nice. And the subject which has been chosen for him is really a one which is complicated. FGR, we all know many times, despite of everything, we are not able to save that baby. So we'll be able to understand the basic pathology and the utmost, the recent most test, what we can do. At the end, I want to say the best wishes to all those who are contesting these days, and lots of best wishes to all of you, Sneha, Bharti, Rakhi. Lots of best wishes to all of you. It's going to be a very nice session, a very academic session and good session. Thank you so much, Sneha.
Thank you, ma'am.
Thank you, madam. Thank you so much for gracing the occasion, and of course your wishes always. Thank you so much. So we would like to invite. I just hope
Dr. Narendra Malhotra sir is there. Ma'am, please invite him.
please.
Yes.
So, I have already introduced sir, but it is always a pleasure to introduce you, sir. I have already said that the name, the organization, you have headed it. But apart from this, illustrious CB, you are such a gentle human being and a very respectable mentor, I would say, who has guided me since the beginning, Foxy. I'm very happy to have you and receive your blessings also, sir. Over to you, sir, for your precious words.
So, namaskar, greetings. Wishing you all a very, very happy World's Environment Day. Today, I've been busy in tree planting everywhere. I'm just coming from one and I have to reach there, the next one in 5 minutes. That's why I'm in the car. I even didn't have time to change into, out of my working clothes. So, I'm right now in that. So, World Environment Day is very, very important. We have to know that endocrine disruptors are everywhere all around us. And this year's theme is plastics. So let's say no to plastics. Let's plant plants and let's try to make our environment very clean and healthy. A bad environment is one of the causes of FGR. And that is what it is, the environmental factors or FGR. And if we cannot curb this, the transgenerational effect of endocrine disruptors to an unborn baby goes for 2 generations. So if this baby is growth retarded because of environmental toxins, next 2 generations are going to suffer from hypertension, cardiovascular disease, diabetes mellitus, obesity, and all that. So we need to understand FGR. We need to understand how to diagnose and how to prevent. That is the main. The next topic, cardiotocography. My thesis was on cardiotocography in long back in the era when it was first being used. And it is another one thing which all gynecologists, obstetricians should have in their clinics and in their labor rooms to monitor antenatal and to monitor labor. And of course, labor emergencies is what we get to know. So congratulations, Sneha, for organizing this fantastic webinar with AMOGs and UPCOG. And I can see so many good friends, teachers, all here. Wish you all the best who are fighting the election or contesting the election, not fighting.
Never fight.
And may you all, we look forward to a very vibrant Foxy with all of you in the helm. Thank you for inviting me as chief guest. I apologize, I have to leave for it, but I will put the speaker on and listen to what is going to be spoken. Thank you very much.
Thank you, sir.
Thank you, sir.
So much for that precious message you have conveyed. Thank you so much for your precious words as well, sir. Nutan, over to you. We can move ahead.
Yes, I would. Is Sadhana Gupta, ma'am? I couldn't see the video on. I wanted to invite her to just share 2 words. Sadhana Gupta, ma'am, are you? Can I see your video on? Yes, ma'am. Welcome, Sadhana Gupta, ma'am. नमस्कार, मैम प्लीज आप अनम्यूट करिए अपने आप को. Namaskar and welcome, Sadhana Gupta, ma'am. It's always a pleasure to see you.
Hello, everybody. And first of all, thank you, Sneha, and all the coordinators for this invite and opportunity so that we meet close friends and all president and secretary of all societies who are involved. And all the what we can say about Sneha, I will like to say few, but that she has been very, very hardworking, and we have seen her working very, very tediously, and especially for her committee and for all the activities. So we wish all the best to Sneha. And my sincere regards to Dr. Usha Sharma ma'am, Dr. Narendra Malhotra, Dr. Jaideep Malhotra, who are like a pioneer in the OB-GYN, and we always look forward for them. Dr. Kiran Kutkoti, Dr. Saroj Singh, who is actually my, like, in person, she has been guiding me since childhood, since the school days, because it is something I never fail to share. That when I was in a school 10th, I look forward to her, how she studied, how she was punctual, and I could imbibe few qualities and could not imbibe till now. So my sincere regards to Sarojji. It is like always great to work with her, and Rakhi, Bharti, Dr. Like, they are very, very hardworking. They have done tremendous work in their committee. So we wish all the best, and it is all about friendship. Like, I have been something fortunate to contest many, many election, and I will say to everyone that with every journey, we come out different, we come out stronger, and I hope that we come out very, very clearer, and uh, with that, like, achieving good goals in our journey. So every journey, like connecting with everyone, sharing knowledge with everyone. So it is something great, and I congratulate everyone who takes this stride. It is not an easy stride, and we should remain friends. We have to remain friends, and we are friends forever. So it is always a life is always a sporting journey, and we should, or we need to enjoy that in the same way. Dr. Murlidhar Pai, academic doyen, and the fetal growth restriction, you have given such a brilliant topic to him, who has all the wisdom and the clinical experience, as well as the great academic background, what to do on fetal growth restriction. CTG is still, we are doing a lot of program, but still when we get CTG recording, sometimes we get confused what to do next, what to repeat, what to do urgent delivery. So Bharti is going to speak, and the Sneha, what he says, she is working in Yavatmal, has a very, very huge practice, and her experience in labor emergencies, it is not only from the books, but it is actually from the life, and we look forward to wonderful discussion with the brilliant panel. So best wishes to everyone, my sincere regards to all seniors, and my all the best wishes to the organizer, as well as the people who are on the journey to have to leadership into the Foxy. So thank you very much.
Thank you, Sadhna ma'am, for your such wonderful words of encouragement. It's always a pleasure to be connected to you.
Thank you. Thank you for your blessings and your best wishes always. Thank you.
Thank you, Sadhna ma'am.
We have our AMOGs office bearers are actually doing their emergency working, all of them. So we'll just pay regards to Dr. Kiran Kutkoti sir, our AMOGs president. And before we start our first session of academic,
Dr. Nutan, we have Dr. Rakhi Singh as guest of honor. So Dr. Rakhi Singh, who is the president of Noida Society, and of course the past chairperson Foxy for the endocrine committee. Of course, she also has lots of awards and accolades to her credit. I would just like to mention a few, that she is the vice chairperson of UP State ISAR and peer reviewer of Jogi. And she has many awards to her credit, including Foxy DC Datta Award, Foxy CS Don Award, and of course many others. So we would like to have a few words from you, Dr. Rakhi. Over to you for your speech.
Thank you, Dr. Sneha and the AMOGs team and the UPCOG team for inviting me over here. And good evening to all the seniors present over here. Dr. Anju, I've been there from Dr. Padmashi, Dr. Usha Sharma ma'am, Dr. Naren Malhotra sir, Dr. Jaydeep ma'am, Dr. Kiran Kurtukoti, Dr. Saroj Singh, Dr. Sadhna Gupta ma'am. We've been hearing a lot from all of them, the teacher of the teachers, who have been great over here, and Dr. Murlidhar Pai, whom we regard as the epitome of the academics, because any topic, whatever he touches upon, he makes that whole topic so easy to learn, even though fetal growth restriction is such a difficult topic. And I bring you greetings for the World Environment Day, that is 6th of June, which is today. And on this Environment Day, I'd like to highlight one thing, that when I was a committee chair, I had taken out an advocacy video on the environmental pollutants and the remedies for it, which I have shared it on the Foxy Friends group also. Do watch that video, because all the teacher of the teachers and the leaders have put in the word over there, a small bite, which have been uh, inculcated into it, so that a nice message goes out at large that environmental toxins are playing hazards and havoc in our life, which we all know, including the fetal growth restriction, which sir is going to talk about, and the emergencies, the labor emergencies, and the, as sir has also said, Dr. Malhotra sir, that it is not only affecting the same generation, but it affects the generations next and next, because any female who's pregnant is pregnant along with the grandson and the great grandson also, and transmitting all the hazards and the NCDs. So all the critical labor and the important decisions have to be taken before that. Over to you. Congratulations, Dr. Sneha, and best wishes for your tenure ahead. And good luck.
Thank you, Dr. Raki ma'am. And we would like to start. Can we start our academic session, ma'am?
Yes, yes. With the blessings of God Almighty and the blessings of respected seniors, we would like to move ahead quickly with the academic session. And with this, I thank everybody for gracing the program. Thank you so much. Over to you, Dr. Nutan, and can we quickly move on to the academic session?
Yes. Now I would like to invite Dr. Pragati Agarwal to take up the academic session and introduce our next topic. Dr. Pragati Agarwal, please.
Thank you, Dr. Nutan. First of all, I want to wish you all happy World Environment Day. Today is 5th June. Many of our members are busy in celebrating this day today. And now I am starting our scientific session. First topic is on FGR, and the speaker is none other than Dr. Murlidhar Pai. I invite the chairperson for this session, Dr. Kalpana Dikshit. Is she here?
Please go ahead, introduce.
Pragati ma'am, you're muted.
Dr. Kalpana is president of Kanpur Ops and Gynae Society, and she is my batchmate and my friend also. Next chairperson, Dr. Deepali Verma. She is the president of Muradabad Ops and Gynae Society, and she is a maternal and fetal medicine consultant, genetic clinic and ultrasound center, Dhanvantri Super Specialty Hospital, Muradabad. And next chairperson, Dr. Anjana Saxena. She is the president of Hapur Ops and Gynae Society, graduation and post-graduation from LLRM Medical College, Meerut. And now she is doing private practice since last 30 years. Now I invite the chairperson to introduce Dr. Murlidhar Pai. Dr. Kalpana, is she here? There was some problem in her connection, I think.
We can ask other two chairpersons, Dr. Anjana, yes, ma'am.
Dr. Anjana, she can introduce Dr. Murlidhar Pai.
Ma'am, please do the honors.
Thank you, ma'am. Thank you so much, Sneha ma'am and Dr. Nutan and all my respected seniors for making me a part of this webinar. Dr. Murlidhar Pai, I don't think needs much introduction because everyone knows him. I'll read it out. He's professor and head of BG KMC Manipal, founder and current chairman, Karnataka College of Obs and Gynecologists. He has given many lectures, 682 lectures, 201 publications, has best teaching material awards, 13 best teaching material awards, 4 best research awards. He's author of Holland and Bruce Obstetrics, 4th edition, and Obstetric and Gynae FPMFU, 1st edition. 36 years of teaching and 30 years of experience as examiner. Please, sir, I'll not be in between you and the topics, sir.
Yes, sir, start.
Can I
Welcome,
upload?
sir. Yeah.
Yes, sir. Yes, sir.
Prerna, can you please stop share and allow sir to share his screen?
1 minute. Good evening, everyone, and I'm really happy and feel blessed that all my senior colleagues have good words for me. And I'm also happy to share that I'm in such a state which is environmental friendly. On this day, I'm happy to say that Sikkim is one of the states which is totally plastic free. As you cross the borders and get into Sikkim, they will check whether you have any plastic bottles. It's been there for last 1 year, 1.5 years. So with that much, let me straight away jump into the topic without wasting the time. So this is a real nightmare for obstetricians, neonatologists, as well as parents. A baby is born with FGR, and here, of course, the added preterm situation also is there. What I would like to say is that pending the understanding and development of methods to reverse the progressive nature of FGR due to placental disease, management is essentially timely delivery. People have tried anything and everything, starting from oxygen therapy, fluid therapy, vasodilators, RG9, left lateral position, anything and everything. But there has been very little improvement in the reversal of the progressive nature of FGR. So the only treatment is timely delivery. When to deliver an FGR baby is obviously $1 million question. One who knows when to deliver not only FGR baby, any baby for that matter, is the super obstetrician. It's always a balance between intrauterine and neonatal death. If you wait too long, the baby will have intrauterine death. If you bring the baby too early outside, the baby can have neonatal death. So an obstetrician has to always walk this tightrope. You cannot err on the side of mother. You cannot err on the side of baby. You have to have a perfect balance. So the balance between preterm delivery versus expectancy. Now, that's what I'm going to talk about, when to deliver an FGR baby. And before that, we all should understand the whole game of this starts when she conceives. It's not after that. Why I'm saying this? I'm saying this because when she conceives and in the initial weeks itself, the vascular remodeling happens. The pathophysiology and etiology of three things are common. What are those? Number one, preeclampsia. Number two, FGR. And number three is preterm labor. In fact, we can say that they belong to the same spectrum. A particular lady may have all the three. She may have only one of them, two of them. That depends upon the other factors that she has. Maybe oxidative stress, the clinical manifestation of preeclampsia, the clinical effect of preeclampsia, that is FGR or preterm labor, all depends upon the rest of the things. So the game begins when she conceives, and the game revolves around how she fares, timing of the delivery. So today I'm going to talk on stage-based management of FGR. Let us now see what is FGR. All of us try to define FGR in terms of 10th percentile, 5th percentile, 3rd percentile, and all those things. Yes, that quantitative measurement is important, but what is it? It is actually failure to achieve the endorsed growth potential. This is qualitative definition, but it truly represents. Why I'm saying so? Because even in now the diagnostics, we don't have to go by the world standards or comparative standards. What do I mean by comparative standard? Traditionally, we have been telling FGR means if the given baby is less than 10th percentile of its peers. Now, this is like comparing our baby with the other babies, which is okay, but it is not fair to the given baby. For example, let's say you have scored 70 marks. Compared to others, you are very good. Maybe you are first rank in the class. But the next time you score 50 marks, still compared to others, you may be the best. But by your own standard, you have gone down. You were scoring 70 marks earlier. Now you have started scoring 50 marks. Still, compared to others, you are good. So this is what is meant by endorsed growth potential. If I have to tell in terms of cricket, other day we had the big cricket IPL. There, they predict at this run rate, the team should score 300 runs in the initial days itself, in the initial part of the game. But then let's say quick wickets fall and the team manages to score only 250 runs. Now that is FGR. They had the potential to score 300 runs, but they stopped short at 250 runs. Still, they may win the game if the opposite party scores less than them. But then, by their own standard, they have not achieved what they could achieve. I hope I'm very clear in this. Why is it important? It is important because if you don't achieve your potential, there can be problems inside the uterus, that is in terms of fetal death, soon after delivery, in terms of neonatal period, a whole lot of problems are there. And not only that, FGR will haunt you. What is according to Barker's hypothesis, these babies later in life can have hypertensive disorders, diabetes, dyslipidemia. And as Dr. Narendra Malhotra said, another 2 generations of this particular baby may also suffer because this baby is carrying all that burden. So that's why, as obstetricians, it is very important for us to identify which baby is lagging behind. Probably that's the right word. Which baby is lagging behind, and we have to get that baby outside at the right time so that we can take care of that baby outside. It is very difficult to take care of the baby when it is inside the mother. That's what I told right in the beginning of my lecture. People have tried to feed the mother. People have tried to give lots of food to the mother. People have tried to give oxygen to the mother, drugs to the mother. But everything is given to the mother, but it is not reaching the baby. Why it is not reaching the baby? Because there is a vascular problem. So when it is so difficult to treat the baby, which is inside the uterus, it makes sense to get the baby out at the right time and directly supplement the baby with whatever it requires. Maybe nutrition, maybe oxygen, maybe other things. So that is the whole thing about FGR. So the growth potential is arbitrarily marked as 10th percentile and above. If it is falling short, then it is FGR. But then it may actually encompass many unnecessary babies. So there is a view that, strictly speaking, we have to go for the babies which are less than 3rd percentile. But I will not get into that debate or controversy. It is always better to catch even if some more babies falsely. That doesn't matter, but we should not miss them. Especially when I talk about late onset, even ninth percentile may be very dangerous. In fact, we did a study in Manipal where we followed the babies which are between 10th percentile and 50th percentile and found out that these babies are also in danger.
How?
Just because the baby is 20th percentile or 30th percentile, we cannot ignore. We have to be very careful about the babies which are between 10th and 50th percentile because they may slip in
बोतल भी करो
less than 10th percentile towards the end.
कल वो क्या कह रही है कल वो सुबह 8 से
Dr. Kanchan,
Can you just mute others, please?
Yeah. So we have to not just go by one number. We have to watch the baby as a whole. So I will straight away jump into the 3 steps of management of FGR. Step number 1, it is very important to differentiate between FGR and SGA. Now, why is this? Now, SGA is small for gestational age. Now, when you say small for gestational age, let us say you expect the baby to be 2.5 kg at this particular gestation, and the baby is, let's say, 2.3 kg or 2 kg. So it is small. Now, just because it is small, it need not be FGR. You may be confused. Let me clarify. The small baby may be because of its constitutionally small baby. Let us say some of us are very short, but we are perfectly all right. Sachin Tendulkar is short compared to Kapil Dev, but he is perfectly all right, isn't it? So small does not mean growth retarded or it is not having any problem. Whereas when we say 2 kg baby, because of FGR, it means a world. I've already explained earlier, fetal growth restriction is pathology, whereas small for gestational age is physiology. It may be the lowest in the normalcy. Suppose, let's say among the children of 10 years, there will be different height and weight, but all of them are normal. The tallest child may be, let's say, 4 feet, and the shortest child may be 3 feet, but both of them are perfectly normal. There's nothing wrong with them. So that is SGA. Whereas FGR means there is a pathology in the placenta. That pathology is affecting the baby's growth. That's why the baby is small, is hugely different from the baby being small physiologically, constitutionally. That may be, for example, I have seen here this part of the country, all are short. That doesn't mean that they are having problem. Whereas in Europe, they are all tall. That doesn't mean that they are better than us. So it is constitutional. So our first step should be to differentiate between whether this baby is just small, otherwise perfect, or whether there is an FGR. Now, how to know that? That is very, very important. Some of the points to diagnose FGR is that these small fetuses are at higher risk for fetal in utero deterioration. As I said, they will deteriorate faster. And not only that, they will die inside the uterus and give rise to stillbirth. And there's an overall poorer perinatal outcome for these babies. So how do you know? There is associated abnormal fetoplacental function, which means usually if the baby is small and the mother is having preeclampsia, we may infer that there is an abnormal placentation. That's why this baby is small and not just constitutionally small. Doppler signs are very important to diagnose FGR. Doppler signs suggesting hemodynamic redistribution as a reflection of fetal adaptation to undernutrition and hypoxia. I need to explain this a little bit more. What is this redistribution? There is uteroplacental insufficiency, so less blood is going to the baby. As a result, the baby will redistribute the blood available for it. So it will obviously send the blood to more important organ, and it's not a very difficult guess. The more important organ is brain. So all the blood is shunted to the brain. Less blood is shunted to the liver. As a result, there is no growth of the abdomen. Abdominal circumference shrinks, whereas there is normal growth of the brain. There is no excessive growth, but there is normal growth of the brain. As a result, there will be an altered HCAC ratio. Head circumference is more than the abdominal circumference. Not only there is decreased blood supply to the liver is looted by the baby of its glycogen reserve. So there is double whammy or double jeopardy. It's an additional reason for decreased abdominal girth. This is one thing. This can be easily made out by simple ultrasound, no need of Doppler. Whereas if you used Doppler, you will find there is peak systolic blood flow is more in middle cerebral artery, and there is decreased blood supply or flow in the placenta, what we call CPR ratio, cerebroplacental ratio. It is in favor of the cerebrum. Initially, there will be excessive flow, as can be made out by Doppler in the middle cerebral artery. But eventually, if there is continued lack of supply from the mother, even that also goes down. And then it further goes down in such a way that there will be reversal also. So we should not wait till such time. So to summarize, redistribution is the hallmark of diagnosing FGR, which includes by simple ultrasound, altered HC-AC ratio in favor of HC, and altered Doppler findings, where the most important thing is CPR ratio, which is definitely abnormal. That means there is more blood going to the cerebrum than what is seen in the placenta, which is seen by the umbilical artery, whereas middle cerebral artery represents the cerebrum. Then, of course, there are whole other things. BPD also you can measure. You can measure femur length, but BPD is not a very good parameter because it has got lot of plus minus. And as I said, because of brain sparing effect, BPD may well correlate with the gestational age. So we don't go by the BPD. With regards to femur length, of course, femur length is not altered. You know why? It is the center of hemopiesis. So because hemopiesis occurs there in the intrauterine life, the femur length is again not altered. So if you ask me, the single most important parameter to diagnose FGR is HCAC ratio. In fact, you have to take both of them. You can't go only by the AC. You will get confused because if AC is small, this could be a small baby. So you have to measure both HC as well as AC and take a ratio. And if the ratio is more than 1, then then it is a problem. So that's how even cerebroplacental ratio also, it should be equal to 1. There should not be any hampering. If the ratio is altered in favor of the cerebral flow, it is FGR. So I would only go by these two. There are so many other parameters, but these two are very, very important to diagnose FGR. Then comes histological or biochemical signs of placental disease. This, of course, after the delivery. This is just proving retrospectively. It is no point, but at least you can prove that, yes, it was a FGR baby, not a simple small baby. After the delivery, you may send placenta for histopathology, and that will show histopathological changes, biochemical signs are also. Higher risk of preeclampsia, which I've already mentioned many times. These patients will also have simultaneous or concurrent preeclampsia to prove that the baby is smaller, not because of constitution, but because of FGR. So that is our first step. Yes, now we have diagnosed our baby as FGR baby. What should be our second step? Our second step is to find out whether it is an early onset FGR or a late onset FGR. Earlier, we used to categorize FGR into symmetrical and asymmetrical FGR, which is not wrong, which can still be done. There, the meaning was symmetrical IUGR means baby is symmetrically small. Now, when the baby is symmetrically small, it could be again a difficult task to differentiate between whether it's a normal baby which is symmetrically small or a FGR baby which is symmetrically small. Slightly difficult to make out that situation. Whereas the asymmetrical baby is the easiest one to diagnose. And if there is asymmetry, it is always due to FGR. That asymmetry is because of redistribution. As I have already explained, I don't want to waste time again. Asymmetry means head circumference is normal, abdominal circumference is small. And of course, subcutaneous fat is also not there. But recently, we have understood what is more important is not symmetrical, asymmetrical. Of course, it is important in a way. Symmetrical FGR is always due to some intrinsic problem. And that intrinsic problem is either a chromosomal problem in the baby or an early viral infection in the intrauterine infection. Both can be detrimental to the baby. To that extent, yes, it's very important. Whereas that is rare. The anomalies as such is rare, and infections have luckily become not that common. What we see in large numbers is a asymmetrical IUGR. In that, what is very important for us is whether it is early onset FGR or late onset FGR. Now, it's an easy guess. People will easily think that early onset is more dangerous. Of course, logically thinking, you say if the FGR has been there from 20 weeks, that baby is not going to have a very good growth, and that baby has got high chance of having very preterm deliveries, either iatrogenic or otherwise. Because I told you, remember, FGR, preeclampsia, and preterm delivery are the problems of the same spectrum. But contrary to our belief, the late onset FGR can be more dangerous. Why? I will explain in the next slide.
Dr. Richa, please mute yourself. Dr. Richa, please mute yourself.
Okay. Yeah, let me explain what are the differences between early onset and late onset. Now, early onset is 20% of the cases, late onset is 80% of the cases. Look at that. Early onset means before 32 to 34 weeks, and usually they land up in early delivery because there's a long standing insult, and if you wait, these babies may die. Whereas late onset FGR, ma'am.
Prerna, please mute everyone else. Prerna, please mute.
Yeah. So late onset means after 32 to 34 weeks. Because the onset is little late already, the baby has crossed 34. So we will be able to deliver them around 37 weeks. Second point, the problem with early onset FGR is the management because it requires a long-term management. Suppose the FGR started at 20 weeks and we are planning to deliver around 36, 37 weeks. You can imagine a 17 weeks management, so much of tension to the patient, to the obstetrician, to everybody. Whereas the problem of late onset is not the management because the baby has grown till 34 weeks nicely and we have another only 2-3 weeks to manage. But the most important thing here is These 2-3 weeks are the most crucial weeks. The problem of late onset is that of diagnosis. What usually happens is we may not do ultrasound after 34 weeks if everything is fine. And this is the time the baby will slowly slip from 10th percentile to 8th percentile, 9th percentile, or 7th percentile. And this baby is going to miss totally our eyes, and that may have sudden IUD. So the problem of late onset is diagnosis, catching them at the right time and delivering them at the right time. In early onset, obviously there is a severe placental disease. Whereas in late onset, there is placental disease, but it is mild. That's why the baby could go normally up to 34 weeks. But thereafter, once the baby has really become big, the available oxygen from this not a good placenta and the available blood flow from this placenta looks little less. It's like that when we are small, little bit food or little bit money is enough. When you go big, and if the money, what you have, if it doesn't grow, you suddenly feel the money is short. That's what happens to this baby. High association with preeclampsia is seen always in early onset, but low association is seen in the late onset. Hypoxia is always deep and profound in cases of early onset, whereas hypoxia may or may not be there. But shall I tell you something? The problem here is when you're always in hypoxia, you somehow get adjusted to it. For example, I'm in Sikkim. I'm used to this weather now. I'm used to these mountains. I'm used to the oxygen and everything. But suddenly, if you come from Delhi, or suddenly if you come from a hot area, you will feel cold here. You will feel less oxygen here, right? So that's why the late onset babies, even if there is slightly less hypoxia, they will feel miserable and they will die also. Whereas these babies are used to having less oxygen right from the beginning, they get acclimatized and they can survive. So it is very, very interesting to see the difference between late and early onset FGRs. Then high tolerance for hypoxia. That's what I just now explained to you. Though they are early onset, though they are very small babies, though are very difficult to manage and all that, somehow they tolerate hypoxia better than a late onset FGR babies who are okay till 34 weeks. And suddenly after 35 weeks, they slip down because of mild problems in the placenta. And these are the babies suddenly feel so much of loss of oxygen. It's like if our child is used to spending 30,000 rupees per month. That's what some of our students always feel. And 1 month, if the money comes little late, the children become miserable. Earlier, we used to tolerate all sorts of pains, all sorts of insults. But nowadays, children cannot tolerate even slightest scolding. That's how it is, the late onset babies. High mortality and morbidity in case of early onset. Here, the mortality is not high, but it is sudden and it's like a bolt from the blue. And really, the patients will not be able to accept at all. They will blame the doctor. Doctor, you told me I came last week. You told me my baby is fine. You did an ultrasound. Everything was fine. And this week I have lost my baby. How come you didn't diagnose this? So that kind of a situation happens in late onset FGR. I hope I have made it very clear so far what is the difference. Now, how do you know this? Umbilical artery, if you do only umbilical artery, it fails to pick up instances of mild placental disease. Which constitutes a proportion of early onset cases and virtually all instances of late onset FGR. So you have to do the middle cerebral artery ideally. Now I come to the third step. First step was differentiating between small for gestation and FGR. Second step was differentiating between early onset and late onset. Now, having diagnosed that, the third step is identifying signs suggesting risk of IUD before term. Now, whatever may be the FGR, whether it is symmetrical, asymmetrical, early, late, what are we worried about? We are worried about sudden intrauterine death. especially in the third trimester. Because in third trimester, losing the baby is unpardonable by anybody. So we should be more worried in the third step, that is to diagnose whether there is an immediate threat to the baby of death. How do you do that? The parameters to identify a poor outcome are very small among small. As I said, all these days it was around 11%, 12%, 15 percentile. It is slipping into 10th percentile, 9th percentile, 8th percentile, and 7th percentile. But if it is going below 3rd percentile, it is foolish to wait thereafter. Number 2, uterine artery pulsatility index. That is okay, but it is not of big consequence. What is more important for us is cerebroplacental ratio. That is middle cerebral artery PI on the numerator, umbilical artery PI in the denominator. If the ratio is more than 1, that means there is definite problem there. If the ratio goes down, it is worse. If the ratio goes up, you are alerted that it is a case of FGR. But if the ratio goes down, means the middle cerebral artery is also not getting enough blood. The baby is closer to death. So it is better to have ratio as 1. Aortic isthmus is a new concept, but if we have done a study in Manipal, we didn't find that much of importance in aortic isthmus, so I don't want to waste much time there. Ductus venosus is the last one to have problems, which is closer to the heart. If you find absent end-diastolic flow of A wave, or worse is reversal of A wave, then the baby is going to die within maybe few hours, not even 24 hours. So these are the very important parameters which you should be following in the third trimester when you see the baby is having or going towards severe FGR. Angiogenic factors are not well developed. FLGA and all epic growth factors, all these things are being now in the experimental stage. You can ascertain the severity or the closeness to death by looking at this, but today it is not well developed. So aortic isthmus, as I told you, it reflects the balance between the impedance of the brain and systemic vascular systems, and reversal of aortic isthmus is a advanced deterioration and further step in the sequence of starting with umbilical artery and middle cerebral artery diapers. It can be found in abnormal, also in small proportion of late onset FGRs. So what are the methods and indices to having fetal assessment? You have to plot the growth on charts for early recognition. Something like this. These charts are now available everywhere. As you can see, when you plot every time and do a serial ultrasound, this is a typical case of late onset. That means initially the growth is normal in the middle and later it flattens. Whereas this one is called low profile. Right from the beginning, it is low. This is the best. Then comes uterine artery. It provides the both diagnostic and prognostic info. MCA, it is like a surrogate marker of hypoxia. CPR, essentially a diagnostic index. And AOI, abnormalities associated with increased fetal mortality and neurological morbidity. Ductus venosus, as I told, strongest predictor of fetal death in FGR. NST, though highly sensitive, has 50% false positive rates for the prediction of adverse outcomes. So you don't go by it alone. If it is abnormal, you take it with a pinch of salt. If it is normal, you are reassured. Now, CTG is sensitive to detect advanced fetal deterioration, but when you are thinking of CTG, that means patient is already in labor. Nobody does the contraction stress test anymore. But if you want to know how the baby is faring now, BPP is the best. What is BPP? Biophysical profile. Though it has no significant benefit in high-risk pregnancies, it will tell you how the baby is doing now. What is the difference between Doppler and BPP? Doppler predicts, BPP tells today how the baby is right now. Of course, amniotic fluid index is a parameter which we follow for a chronic deterioration. So having understood all these things, it's easy for me to now explain the management of SGA, stage-based management. FGR. Before that, how to manage SGA? You have to first exclude the infectious and genetic causes as a cause of a small baby. Once you rule out that, you have to simply do fortnightly Doppler and growth assessment. And then, of course, you can induce the labor at 37 completed weeks and deliver them. Why? Because these are normal babies. There is nothing wrong. They are small babies. You have already ruled out genetic problem and infectious problem. So treat them like a normal baby, but a small baby. But this is very important. Stage-based management of fetal growth restriction. For the first stage, here there is severe smallness, maybe less than third percentile, or mild placental insufficiency. What is the criteria to say this? Estimated fetal weight, as I just now said, less than third percentile. Umbilical artery PI is more than 95th percentile. MCA PI is less than 5. Uterine artery is more than 95 and CPR is less than 1. What do you mean by less than 1? Even cerebral flow has come down because the middle cerebral artery is on the numerator, umbilical artery is the denominator. So if upper numerator is less, obviously CPR ratio will be less. It's a serious problem. But you can just monitor them weekly and you can take these babies in stage 1 up to 37 completed weeks. You can induce labor. You can even give a vaginal delivery for them. Whereas when they go to second stage, where there is severe placental insufficiency, how do you know that? There is absent end diastolic volume in the umbilical artery. Umbilical artery, absent end diastolic volume. And there's a reversal of aortic isthmus. These babies you have to monitor bi-weekly. How do you monitor? By BPP. PPP automatically includes NST. You have to do Doppler studies. And these babies, you have to deliver by cesarean section. If they have completed 34 weeks, nothing more to gain, only to lose. So conduct the delivery. There is actually no need to give even steroids and neuroprophylaxis because they have completed 34 weeks. However, if your neonatologist suggests, give at least couple of doses of the betamethasone, you can do that. Third stage is already there is low suspicion of fetal acidosis. How do you know that? Umbilical artery, not only absent diastolic volume, now there is reversal of end diastolic volume, which is dangerous. And ductus venosus PI is more than 95. How do you monitor? Not bi-weekly, every day or alternate days. Delivery, once they cross 30 weeks, nothing to gain. Just give 2 doses of steroids, maybe neuroprophylaxis because they're less than 32, conduct cesarean section and deliver them. Neonatologist will be able to manage them better. Fourth stage, where there is high suspicion of fetal acidosis. How do you know that? Ductus venosus, there will be reversal of A wave and there are already decelerations in the fetal heart rate. All that you have is maybe 12 hours to go or 24 hours to go. So monitor them very frequently, maybe 4th hourly, 6th hourly, even 12th hourly also okay. But deliver them as early as possible. In foreign countries, they deliver once they cross 24 weeks. Here, up to 28 weeks, we consider it as non-viable. But if you have fantastic neonatology setup, you can conduct delivery as early as 26 or 28 weeks, even in India. So this is the summary in one slide. You can take a screenshot if you want. Now it's time to deliver my own formula. It's Murli's formula. AC less than 5th percentile. Murli's rule of 5 I have made. Raised PI in AY. Reversal of flow in umbilical artery. CP ratio less than 1. Absent A wave in DV. BPP less than 5. AFI less than 5. So what is Murli's rule of 5? Same thing. AC less than 5th percentile, BPP less than 5, AFI less than 5, abnormality in any of the 5 vessels. Which are the 5 vessels? Uterine artery, umbilical artery, aortic isthmus, middle cerebral artery, and ductus venosus is the vein. Okay, so 5 vessels. So this is the rule you have to deliver. So if there is a preterm situation along with FGR, what are the problems you anticipate? Respiratory distress and TTN. neurological deficits also. It can be intraventricular hemorrhage, HIE or PVL. Long-term, cerebrocephalus, cerebral palsy, behavioral defects, and hearing loss, epilepsy, and blindness. So what is the mode of delivery of preterm babies? Routine cesarean section for the purpose of improving preterm newborn outcomes is not recommended according to WHO. However, if the baby is less than 34 weeks and if it's less than 1,500 grams, especially in malpresentation, it is always better to go for cesarean section. And of course, I don't have to say, if it is vaginal delivery, deliver in a controlled fashion by using forceps. Patient may think, why are you using forceps for a small baby? Because to deliver the head in a controlled fashion in a cage of the forceps, sudden delivery of the head can cause intraventricular hemorrhage. What is the neuroprotection to be given? To prevent or stop preterm labor, progesterone, tocolytics, and cerclage. Query. Treat infections, of course, antibiotics in case of PROM. Steroids is a must if it is less than 34 weeks. Betamethasone is better. B for better. And magnesium sulfate is for neuroprophylaxis if the baby is less than 32 weeks. It is same as Zuspan regime. Delayed cord clamping is now the rule, 1 to 3 minutes after the delivery. And after the delivery, neuroprotection will be thermal care, that is kangaroo care, non-invasive ventilation, surfactants, RDS, caffeine, breast milk, adequate nutrition, and supportive care. This is basically neonatologist's job. Intrapartum, the 5 important things, highest risk for obstetric harm can be inappropriate use of oxytocin, failure to recognize fetal distress, and even after detecting, failure to use appropriate instrument or timely cesarean, or after the delivery, failure to properly resuscitate. These are all in succession. First is the uterine contraction, fetal distress, vacuum, cesarean. You have to do everything properly. So as far as intrapartum care, strict adherence to labor care guide or partogram, whichever is convenient to you. Continuous fetal monitoring, electronic fetal monitoring is better. That's what Dr. Malhotra was also saying. Every 15 minutes, auscultation is equally good. Early detection of fetal distress, active management of labor, either ARM plus or minus oxytocin. Once you do ARM, if there is meconium staining of flaker, no need to start oxytocin, go for section. Timely and careful instrumental delivery, avoid late cesarean sections. So this is going to be talked by Dr. Bharati, so I'm not going to dwell more on this. As far as FIGO is concerned, there are 3 parameters: basal heart rate, variability, deceleration. Based on that, what is normal, what is suspicious, and what is pathological is defined, and then what intervention has to be done. If it is normal, no intervention. Suspicious, rule out correctable causes, secondary investigations like fetal blood sampling, which is not done anymore. And if it is pathological, urgent action, that is expedite delivery either by instrumentation or by cesarean section. The same thing is put in a different way by NICE guidelines 2017. They say reassuring heart rate 110 to 160. Variability should be 5 to 25 beats per minute. Deceleration are none, early or variable, and less than 90 minutes. Whereas non-reassuring electronic fetal monitoring is 100 to 110 or 160 to 180. One is very low, one is very high. And variability has totally lost, and deceleration is there for more than 90 minutes. Whereas abnormal means heart rate is less than 100 or more than 180. Variability is totally lost or sinusoidal pattern. And you see now late decelerations, which are lasting for more than 3 minutes. And based on that, they have categorized as normal means, of course, such as low risk fetal acidosis, all features are normal. Heart rate is normal, variability is normal, no deceleration. So you can just wait. Whereas suspicious means suggests a medium risk of fetal acidosis, where 1 non-reassuring feature and 2 normal or reassuring features. That means maybe let's say 1 of them only is non-reassuring, others are okay. Pathological means 1 abnormal feature or 2 non-reassuring features. So what you must do, if there is any of these indicates need of urgent intervention, bradycardia or a single prolonged deceleration with baseline below 100 beats minutes or lasting for more than 3 minutes. You have to deliver immediately. Thank you so much for your patient listening. And I would like to now conclude this.
Thank you, Doctor. Dr. Kalpana, can you conclude this? Dr. Kalpana?
You have to unmute Dr. Kalpana. She's trying to speak. Please unmute yourself. Yes.
Thank you, Muralidharan sir, for a fantastic lecture. It was very well explained, and the difference between the small for date for the SGA and IUGR, that is FGR, that was very well explained. How it is constitutional in SGA, and how we have to differentiate between the early onset and the late onset, and how Doppler is very important in such situations, and why monitoring is very important when it is a late IUGR. So close monitoring will avoid most of the IUDs which are a havoc for both the obstetricians and the patients. So thank you so much for your guidance on this topic.
Thank you. Thank you so much.
Dr.
Thank you very
Deepali,
much, sir.
Dr. Deepali, will you add something?
Yes, good evening. Good evening, sir. Wonderful organized webinar. And sir, it was very informative talk, and it is very important to decide the timing of delivery when we detect the fetus of FGR. And all we depend is on Doppler, and the timing of delivery should evaluate the risk versus benefit in delivering a premature baby versus a chronic compromised hypoxic fetus. So it is very important and should be discussed again and again. Thank you so much, sir. Thank you, Pragati ma'am, and thank you, Sneha Bhuyar ma'am, for involving me. It was a wonderful opportunity.
Yeah, pleasure.
Thank you. Thank you, Dr. Deepali. And
pleasure
now
to
the next topic is
Thank
CTG.
you so much, sir, for delivering. Yeah, well, Pragati, just one comment from me. Thank you so much, sir, for delivering this topic. It was much needed, I suppose, for the practicing obstetrician, especially. And you have very well touched, especially the practical tip which you have given about the late FGR, where people talk about it. Things were normal till now. What happened suddenly? The sudden unexplained stillborn, which we should be very cautious. As sir has already talked about that the late onset fetus who is not adapted to this low hypoperfusion as well as hypoxia is more prone to succumb to this. And that is how I think all of us, for all of us, it's the best learning today. So thank you so much once again for accepting our
And also,
invitation.
madam, sir, the rule of 5 that you told was very nice to understand because it is never given in any book.
Yeah,
but
that's
it is a
Murli's.
good rule.
I only started that. So I'm calling it Murli's, and I patented it in a sort. Anyway, I just
And
thought
it's easy to remember.
why don't you make it? Yeah.
Yeah, so it's
That's how
easy
the
to
teachers
remember
always teach us.
and take.
We have to make
Yeah,
some
yeah.
gimmick for them to easy understanding. So I
With
wish
looking
Dr.
for this
Sneha
rule.
all the best for her elections, because I know that she has been working so hard for last 3 years, definitely, and much before that as well. And I sincerely feel she deserves to be a representative in the Foxy in that position. Thank you so much.
Thank you, sir. Thank you so much. Thank you so much. We can go ahead, Dr. Nutan.
After the detailed talk on discussion on fetal growth retardation, we come to our next topic, and we have a very, very dedicated person here for the next topic, Dr. Bharti Maheshwari, who has been the backbone of UPCOG as a secretary. She has added lots and lots of academic and various other activities to the this forum. So Now I would like to Dr. Pragati to introduce next session. Dr. Pragati, please.
For this session, I invite our chairpersons, Dr. Archana Rathod. She is the president of Yavatmal Ops and Gynae Society. May I have her CV? Yes. She is MBBS BIMC Pune and DGO with 2 gold medals from KEM Hospital, Mumbai. She is ex-registrar KEM Hospital, Mumbai. And welcome, Dr. Archana.
Hello,
And
ma'am.
next chairperson, Dr. Rajen Chauhan. He is the president of Palghar Ops and Gynae Society. May I have his CV? Dr. Rajendra Chauhan. Yes. He is the chairman of Kanta Maternity Hospital, Palghar, and practicing Ops and Gynae in rural area, Palghar, organizer of blood donation camp. Welcome, Dr. Rajendra.
Yes.
And the next chairperson is none other than Dr. Kiran Pandey. She is my mentor also, and everyone knows her very well. She is the ex-HOD of GSVM Medical College. She is chairperson Medical Education Committee FOXY and professor and former HOD Department of Ops and Gynae GSVM Medical College Kanpur, Professor GMC Jalayu UP, ICOG Governing Council member 2021 to 23, peer review and Journal of Ops and Gynae since 2021. Welcome, Dr. Kiran Pandey, ma'am. Now I hand over to the chairperson to introduce Dr. Bharti Maheshwari. Dr. Archana Rathod.
Yes,
Yes,
Dr.
ma'am.
Archana, thank you.
Yes,
Please,
ma'am. Yes.
please introduce her.
Yes, at the outset, I thank Sneha madam who has involved me in the webinar of UPCOG. I had already participated with Dr. Bharti madam on 22nd of May. And Bharti madam, she is a professor and head of Department of OBGY and IVF Muzaffarnagar Medical College and Hospital, President of Merit Obstetric and Gynec Society, ISOPAB Merit and Menopause Society. She is the secretary of UPCOG, FOXY ICOG Governing Council member, and she was FOXY MTP Committee chairperson in 2018 and 20. Madam, I had already attended your webinar of labor monitoring, and I know you will definitely give some other new ideas about this CTG. Over to you.
So,
Dr.
thank you.
Bharti.
Am I audible, Dr. Nutan and
Yes,
Dr.
Yes, ma'am.
Pragati?
Yes, ma'am. Yes,
yes, you
ma'am.
are
You are.
good.
Yeah. So thank you very much. And I am so proud of you, whole team, that how you are organizing and in fact doing such a dissemination of knowledge, I must say. As the UPCOG, it is a so prestigious platform from 1986. And Sneha, congratulations to you, Dr. Sneha, that as you want to associated AMOG societies here. So today's, as we all know, that from all UPCOG, regards to all UPCOG office bearer, as well as our chief guest and advisors, Malhotra couples, as well as our all guests of honor, president of UPCOG, vice president of UPCOG, आपका AMOG's president, as well as all very appreciation to coordinators, Dr. Pragati and Nutan, those done so much of hard work to united all societies as well as the speakers and chairperson and all. And then, of course, very much fan of Dr. Murlidhar Pai. We all give, lots of regards, lots of appreciation for his academic knowledge, and not only that he has that knowledge, but how he disseminate that. So today, very important topic, FGR, because we always remain with our patients to how to confirm the diagnosis and how to manage appropriately. And then, of course, different societies of all UPCOG, those in this particular webinar, though they are present in many webinars of UPCOGs, Agra, Hapur, Muradabad, Greater Noida, Kanpur societies, as well as Yavatmal Society. Dr. Archana, we were in last webinar and we have done lots of discussion on the labor monitoring, and Palghar Society, Dr. Rajendra. So come to our topic, and that is I am sharing my screen. Please allow me to share. Stop sharing of this. Yeah. So as we know that today is the World Environment Day. That is really very important thing, and all of you should give importance to that. that the word environment is really, and in fact, environment of our all surrounding is really very important, and this needs attention. So, World Environment Day, like all of your UPCOG, all UP societies have done lots of work today. Same with the merit also, and that comes to the, as Dr. Sadhna said, the journey of UPCOG, as well as from Foxy, ICOG, really enjoying a lot, and especially for dissemination of knowledge. And as you have seen that the MTP committee journeys, we have done lots of work with all of you as well as all over the country. And really, when we work together, then it really impacts. And as we know that MTP documentation, that was so much, many was not aware, and now we have lots of work and lots of awareness about that. So now comes to the main topic, that is fetal surveillance, and important part is CTZ monitoring. I have to focus in next 15 minutes about CTZ interpretation, how actually it should be done, and what is the thing do and don't. So as you know, the CTZ is an important part of intrapartum monitoring, and its goal is to timely identification and rescue of the fetus at risk of neonatal and long-term morbidity from intrapartum hypoxic insult. So CTG, like you will be, you should know this fact that confidential inquiry into stillbirth and death in infancy report in 1997, so long back, they have found suboptimal care in three-quarters of babies all over world who dies from an intrapartum related cause. And most important criticism was found, that was electronic fetal monitoring. And this report, not only this, they highlighted that failure to initiate CTG when indicated. Now, lots of work is done, and now CTG is very much popular. And all high-risk pregnancies, many high-risk pregnancies are, in fact, they are using VR CTG in there. Then failure to ensure good quality CTG. Of course, we all have to learn this. And inadequate CTG interpretation and failure to communicate the finding to senior staff in timely manner. Of course, we have to work on this also. So the conclusion resulting from these findings included recommendations for a regular rolling program of training in use of CTC, simple guidelines on interpretation, as well as guideline on appropriate management in situation when abnormal CTG is there. So we all know that CT is the test used in pregnancy to monitor both fetal heart pattern as well as contraction of uterine. It should only used in the third trimester when fetal neural reflexes are present. Its purpose is to monitor fetal well-being and allows early detection of fetal distress antenatal or intrapartum. An abnormal CTG indicates the need for further invasive investigation, and untimely may lead to emergency cesarean section. So we all know when to do in all high-risk pregnancies like hypertension, diabetes, anemia, cardiac disease, collagen disease, renal disease, all obstetric history, post-treated pregnancies, as well as the fetal indication when there is reduced fetal movement, suspected FGR, abnormal FHR by auscultation, multiple pregnancies, recess isoimmunization, and before induction of labor. Now the questions come when it should be done and how frequently. So usually every 7 days, twice weekly testing is advocated by some in like post-treated pregnancy, diabetes, fetal growth restriction, as well as hypertension. Additional testing is performed for maternal or fetal deterioration regardless of time elapsed. Other perform non-stressors daily or even more frequently. So we all is familiar with the CTD machine. We all know that this can be done externally when the machine used is called when we involves our transducers plate on the abdomen of a pregnant woman, and internal when we place the transducer on the fetal head. So normally the machine we do the setting of the CTG machine is also important. We commonly use the external transducer, and setting of CTG machine paper speed is very important. 1, 2, or 3, it could be option, as well as on the, this is on the horizontal scale. And with the vertical scale, you see the sensitivity displays are set of 20 or 30 beats per minute. FHR range displays of 30 to 240 beats per minute, as well as uterine activity internally 0 to 100 millimeter and external 0 to 100 relative unit. So here you can see the horizontal scale where paper speed, which here in this case particularly 1 centimeter per minute speed is there, and 3 small vertical per centimeter means 10 beats in a small space. The fetal heart rate is commonly recorded with paper speed at 1 centimeter per minute compared with 3 centimeter. Reason that though 3 centimeter is the most accurate for abnormalities, but 1 centimeter less paper is used, but comparatively less accurate and used for screening. Then one thing you all should know when you are doing CTD, acoustic stimulation test. What it is doing, it is provoking acceleration of FHR, and the acoustic stimulator is positioned on the maternal abdomen and a stimulus of 1 to 2 seconds. Please mute yourself, those who will be speaking. It may be repeated up to 3 times.
Prerak, please mute everyone.
It shortened the average time for NST from 24 to 15 minutes. Now come to interpretation of CTD. So this is a very small, unique formula or structured where DRC bravado, Dr. C bravado. So every word they give, structured interpretation. The word DR means defined risk. In every case, first you have to do defined risk. Second thing is C means contraction. BRA means baseline rate. A V variability, A acceleration, D deceleration, O overall impression. So the most popular method that can be remembered, that is by DRC bravado. So define this in every case. You have to define whether it is having any high risk or not. And if pregnancy is high risk, then threshold for intervening should be lowered. So all high risk pregnancies, already I have told you that all are high risk pregnancies. Then come to second point, that is C, contraction. Here you have to record the number of contractions present in a 10 minutes, and each big square is equal to 1 minute. Here in the you can see in the CTD. So each big square is 1 minute, so 10 square in 10 minutes, and 10 minutes, whatever contraction you see, they has to be maintained. Like in this slides, you can see the 3 contraction in 10 minutes, then it would be 3 in 10. Individual contraction are seen as peaks on the part of the CTD monitoring uterine activity, and always you should assess contraction for the duration and as well as for intensity. Then comes to the baseline rate of fetal heart. This is very important part, and it is the average heart rate of the fetus in 10 minutes window. Look at the CTD and assess what the average heart rate has over the last 10 minutes. Ignore any acceleration or deceleration. A normal fetal heart rate is between 120 to 160. Here you can see that in the 10, you can see the fetal heart rates, and here this has to be seen in the 10 minutes window. So you ignore the acceleration and deceleration. So see average fetal heart rate. And it is in this particular slides, it is baseline rate is 140, and heart rate is depicted 20 to 200, in the range. So whatever the average heart rate you can see, and it is in this particular is 120. Then come to the, you should know if it is tachycardia, then could be because of hypoxia, chorioamnitis, hyperthyroidism, anemia, or fetal tachyarrhythmia. And if bradycardia, then if it is less than 120, then of course could be post-dated or abnormal presentation. Severe prolonged bradycardia, it is significant and it indicates severe hypoxia. And it could be because of prolonged cord compression, cord prolapse, anesthesia, maternal seizures, or rapid fetal descent. In the cause of tachy or bradycardia, it cannot be identified and corrected, then immediately delivery is recommended. Then come to, after defined risk, contraction, baseline heart rate, then come to V variability. Baseline variability, it refers to variation of fetal heart rate from one beat to the next. Variability occurs as a result of interaction between the nervous system, chemoreceptor, baroreceptors, and cardiac responsiveness. It is a good indicator of how healthy the fetus is at the time. This is because a healthy fetus will constantly be adapting its heart rate to respond to change in its environment. Normal variability is between 10 to 25. To calculate variability, you look at how much the peaks and trough of the heart variate from the basal heart line. Like in this slide, you can see very clearly that you can see that these are the peaks and troughs of the different heart rate, and it should be in between 5 to 20. If it is less than 5, then of course it is abnormal. And you can see, has to be see it 20 minutes. If you are not able to see, then you can extend for further 20 minutes. And abnormal is seen when less than 5 variabilities for more than 90 minutes, then it is definitely abnormal. So variability is reduced it because of fetal sleeping. So acoustic assimilation should be used. It's beside that fetal acidosis, hypoxia of any region, and it becomes more important when it is associated with deceleration also. As well as fetal tachycardia, drugs by some drugs effect, it is also lowered variability like methyl dopa, magnesium sulfate, benzodiazepine, and prematurity. Variability is reduced at earlier gestation. Congenital heart anomalies in this is also reduced. Then come to, after variabilities, come to acceleration. Acceleration are increase in the basal heart rate of more than 15 beats for more than 15 seconds. This criteria all of you should remember, and its presence is reassuring. Antenatally, there should be at least 2 acceleration every 15 minutes. But acceleration occurring alongside uterine contraction is a sign of healthy fetus. Like you can see in this picture, there is a uterine contraction and you can see the acceleration. So if it is associated with it, then it is definitely a good sign. However, the absence of acceleration with the otherwise normal CTG is of uncertain significance. So acceleration, you should know that how it is when it is associated with contraction, then of course it is important. Then comes to the deceleration. You know, we all are scared of deceleration. When we see CTD and we see deceleration, oh, it is deceleration, but one should understand that which deceleration is bad and you have to immediately intervene and which deceleration you can manage conservatively. All decelerations are not bad. So deceleration are an abrupt decrease in baseline heart rate, again 15 beats, more than 15 beats per minute for more than 15 seconds. There are a number of different types of deceleration, each will with varying significance: early, variable, late, prolonged, and sinusoidal pattern. When we talk about early deceleration, early means its relation to contraction is early. Here you can see in the picture. So this type of deceleration, they quickly resolve once the uterine contraction ends. So you can see that this is a deceleration, but it ends when the uterine contraction and before it resolves. So this is due to increased fetal intracranial pressure causing increased fecal tone. And this type of deceleration is considered as to be physiological. As pressure reduces, it reduces. Then comes to the variable deceleration. Variable when there is a seen in rapid fall in basal line fetal heart rate with variable recovery. They are variable in their duration and may not have any relationship to uterine contraction. Most often seen during labor and in patients with reduced amniotic fluid volume. They are usually caused by umbilical cord compression. Umbilical vein is often occluded first, causing the acceleration in response, when the umbilical artery is occluded, causing a rapid acceleration. When pressure on the cord is reduced, another acceleration occur, and then the baseline rate return. So acceleration before and after a variable deceleration are known as shoulder of deceleration. So this is good. Once you see that before deceleration there is a small acceleration, it is always good, and its present indicates that fetus is not yet hypoxic and is adapting to the reduced blood flow. So how you can see that there is variable deceleration? You can see once you see the any picture of CTD, you should try to find out it and correlate it with uterine contraction, and you see where your deceleration ends, whether it as the contraction ends before it or after it, and how long it persists. So the presence of persistent variable deceleration, they indicate the need of close monitoring. And variable deceleration can sometimes resolve if mother changes position. There is no harm, you change the position of mother and you can give some IV lines, you can give oxygen. So sometimes it automatically resolves. Variable deceleration without the shoulder is more worrying, as it suggests that fetus is hypoxic. Then comes to late deceleration. This is a bad thing. This is the most bad prognostic deceleration, and especially if this is prolonged. So late deceleration begin at peak of uterine contraction, recover after the contraction end. So always see like this is, you can see contraction and deceleration is ending after the contraction end. And this is because of insufficient blood flow through the uterus and placenta. As a result, blood flow to fetus is significantly reduced, causing fetal hypoxia and acidosis. And this reduced flow can be caused by hypotension, maternal hypotension, preeclampsia, and uterine hyperstimulation. And here, please note one very important thing, that presence of late deceleration is taken seriously, and fetal either you can do fetal blood sampling for pH indicated. If it is acidotic, then of course it indicates fetal hypoxia and need for emergency cesarean section. Then prolonged deceleration, a deceleration that lasts for more than 2 minutes. And if it lasts between 2 to 3 minutes, it is classed as non-reassuring. If it is lasts longer than 3 minutes, it is immediately classed as abnormal. Action must be taken quickly, like fetal blood sampling on emergency cesarean section. So in this particular picture, you can see that there is a prolonged deceleration and it is lasting for more than 2 minutes. An example of this is prolonged deceleration, like you can see in the relation to uterine contraction, and this deceleration more than 15 minutes and lasting for around 2 minutes. So when such picture is there, then again you have to think seriously and immediately action has to be taken. So here you can see the slide where all type of decelerations are compared. Early deceleration, I have already told you, it could be physiological. Late deceleration with preserved variability. Again, it could be because of cord compression and you can change the position. It could be reversed, but of course close monitoring is there. Variable decelerations, here you can see if it is prolonged, then and there you can see here very beautifully the shoulder of the deceleration. That this is the deceleration, and before that there is a little acceleration. So if it is such, then of course fetus is not such hypoxic, you can do close monitoring. And then severe variable deceleration, here you can see the picture, you can compare in relation to uterine contraction, there is a deceleration which is persisting even after uterine contraction ends and for longer duration. So if such type of deceleration is there, and if it is lasting for more than 1 minute, 2 minutes, then definitely may lead to acidosis and fetal distress. Then last thing comes deceleration, a type of deceleration that is sinusoidal pattern. It look like just like this sinusoidal pattern. It is rare and it is associated with high rates of fetal morbidity and mortality. And here you can say a smooth, regular, wave-like pattern. And frequency of 2 to 5 cycle a minute, stable baseline heart rate around 120 to 160 beats per minute, no beat-to-beat variability. And this indicates severe fetal hypoxia, severe fetal anemia, fetal-maternal hemorrhage, immediate C-section indicated for this kind of pattern, and outcome is poor. So now come to overall impression. So we have done the DR, defined this C contraction, baseline heart rate, V variability, A acceleration, D deceleration, now O overall impression. So once you noted all these things, then how you have to report? It could be reassuring, suspicious, and pathological. The overall impression is determined in these terminologies. A normal CTG when all 4 features are classified as reassuring. Suspicious CTG when one feature is classified as reassuring. And pathological CTD when more than 2 features non-reassuring or more than 1 feature classified as abnormal. So what is abnormal and what is normal suspicious? So here tell you this is the all table. We have 4 parameters: baseline fetal heart rate, variability, deceleration, acceleration. They are considered for defining reassuring, non-reassuring, abnormal. Reassuring when all 4 parameters are normal. Non-reassuring when there is little abnormalities like fetal heart rate is 100 to 180 and less than 5 for 40 to 90 meets variability. Typical variable deceleration with over 50% of contraction for over 90 minutes. Or single prolonged deceleration up to 3 minutes, then it is non-reassuring. And the accelerations, if we talk about in the non-reassuring, the absence of acceleration, otherwise normal trace, is of uncertain significance. Then comes to abnormal. Abnormal FHR tracing when there is less than 100 or more than 180, sinusoidal pattern when it's more than 10 minutes. This is always abnormal. Then variability less than 5 for 90 minutes, then it is abnormal. Deceleration, either atypical variable deceleration with over 50% of contraction or late deceleration over 30 minutes. Single prolonged deceleration for more than 3 minutes is always abnormal. So if you again see overall impression, I have told you all things: reassuring, non-reassuring, and abnormal. So pathological CT when more than 2 features are non-reassuring or more than 1 feature is abnormal. And suspicious CTD when 1 feature is non-reassuring while remaining features are reassuring. And in the normal CTD when all 4. So now I think you are very clear. When all 4 are normal, you have to write down reassuring. When only 1 feature is non-reassuring, you have to write down suspicious. And when more than 2 features are non-reassuring, you have to write down pathological, or 1 feature is abnormal, more than 1 feature, then it is pathological. So intrapartum fetal monitoring, uncomplicated pregnancy. What is recommendation? For a woman who is healthy and has an otherwise uncomplicated pregnancy, intermittent auscultation should be offered as recommended in labor to monitor fetal well-being, either using Doppler or Pinar. In the active stages of labor, intermittent auscultation should occur after a contraction for a minimum of 60 seconds and at least every 15 minutes in the first stage, every 5 minutes in the second stage. So the maternal pulse should be palpated if FHR abnormality detected to differentiate the 2 heart rates. And then come to in which cases continuous EFM in low risk women, whether it is indicated to, of course, you can do it in the significant or light muconemia like abnormal FHR detected by intermittent auscultation, maternal pyrexia, they are fresh bleeding, oxytocin used for augmentation or women's request. Continuous EFM in low risk women, what is the observation or what is the what of the fact says that there was a borderline evidence that continuous monitoring were more likely to have an instrumental birth compared with the auscultation group, although there is no evidence of differences in augmentation, perinatal mortality, or other neonatal morbidities. So this is a very classic situation which is presented by WHO, that a mother with a history of previous C-section was admitted in early labor and had continuous CTG monitoring. The CT and she is on the epidural for pain. The CTG became difficult to interpret with suspected high baseline and variable deceleration. On the vaginal examination, cervix was 9 centimeter dilated. After 1 hour, it was noted that tachograph was not recording the uterine contraction and there was no longer palpable abnormality. After discussion with the consultation, the decision was made to commence an IV oxytocin because there was no adequate contraction, it was thought. When delay in the second stage of labor was diagnosed, as woman was 9 centimeter, decision was made to increase the oxytocin again, and there were preparation for trial of instrumental delivery. As this was discussed and agreed by consultant obstetrician, the CTD was described as reassuring. However, in retrospective review, the maternal heart rate was 120 beats per minute, and it seems likely that CTD was recording the maternal rather than fetal pulse. The obstetric registrar performed a forceps delivery of a stillborn infant, and this was followed by fresh vaginal bleeding, which persisted after the repair of perineal tear. The consultant attended, and when mother started to complain of shoulder tip pain, the possibility of uterine rupture was considered. So a second consultant was called and laparoscopy performed confirming the uterine rupture. So what is the message? That this message is the need to be alert to the other aspect of CTG, the tachograph. Had the sudden loss of contraction in a mother with a previous C-section been considered more thoroughly, the diagnosis of uterine rupture may have been made earlier, preventing the outcome. And in the other way, the same way, like another case where the mother attended with a history of pink vaginal discharge and contraction, continuous CTG demonstrated a prolonged deceleration and mother was transferred to OT. The fetal heart rate recovered and she was transferred again delivery room with the plan to perform ARM if deceleration persisted. After a further deceleration, ARM was done at 4 centimeter dilatation, revealing thick meconium. The fetal heart became difficult to monitor. An attempt to place the fetal scalp electrode lasted more than 30 minutes. When a second CTD machine was used, it also failed to record the fetal heart. Eventually, the operating registrar had asked to perform ultrasound. A fetal bradycardia was noted and category 1 C-section was performed. The baby was stillborn. So again, what is the message? When a fetal heart rate becomes undetectable, maternity team need to act quickly to ensure that fetal heart is satisfactory, although fetal scalp electrodes are a recognized way to monitor fetal heart and monitor the fetal heart when the trans-abdominal route is unsatisfactory, but they can still be unreliable and it can take time to establish a good rate. So good quality, continuous recording of both the fetal heart rate and uterine contractions are a critical prerequisite for adequate CTG interpretation. Trying to achieve this in a timely manner can be intrusive, but it is the duty of health providers, when appropriate, to find a way to adequately monitor women and their babies in labor. So ultrasound scanning should be used to exclude severe heart rate abnormalities when a CTG recording cannot be obtained reliably via trans-abdominal transducer or a fetal scalp electrode. So recognition often prompt action when faced with a pathological CTG. A significant proportion of reviews identified that healthcare professionals either didn't recognize the pathological CTG or didn't act upon a pathological CTG even when it was recognized. So finally, in the summary, the key management decision should be based on CTG. Interpretation alone should not be there. When reviewing a continuous CTG, always healthcare professional should take into account the full picture, full clinical picture of the patient, including mother's history, stage and progress in labor, any antenatal risk factors, and any other sign the baby may not be coping with labor. A CTG should not be reviewed as a stand-alone investigation. So this was about the CTG, and in last 2 minutes only, just whatever we have discussed, a 1 or 2 case, real life case, what from my departments, I can tell you this is one patient which she was admitted with a 35 weeks of pregnancy, according to first trimester ultrasound, with previous 2 normal vaginal delivery and decreased perception of fetal movement. And when on examination, everything was normal and she was in the unaffected vertex -3 early labor. And early labor, and when her CTG was done. So what it was, and like a Doppler CTR, it was also less than 1, and 32-week gestation has a oligohydramnios or ultrasound. And on CTG here, you can see the picture. You can find out the prolonged deceleration. So of course, under the prolonged deceleration, no acceleration, beat to beat biopsy present, but it is less than 5. Then prolonged rate acceleration. So of course, the case expected for the non-reassuring CTG and deranged color, definitely emergency seizure section was done. Again, this is the CTG of one patient. Here you can see this is the deceleration, which is a long variable deceleration. And here you can see 15 beats per minute, and beat to beat variability is present, good variability. No acceleration you can see in this whole picture, and fetal heart rate is 126. And this patient calm with 29-year 37 labor with decompression should be write down like that. First, high risk factor if it is there, then with fetal heart rate, acceleration, deceleration, and overall impression. So this should be write down, and then validation has to be done. So in this cases, if there is a sudden increase in the fetal heart rate, it could be due to cord prolapse. So these are the certainly you can say this is the sinusoidal pattern. The patient is the eclamptic, and the came and this is the it's CTG tracing. So again, patient was taken for the cesarean section. So this was about that CTG. The good you can see the department's CTG tracing, and you can see very beautifully that contractions and how you can see that it is a admission CTG in the some patients and find the good oscillations variability. So it was found to be normal reassuring CTG. This is again from the department in CTG first post induction. And again, in this case, overall impression is reassuring. So such type of PCT here, you can say that the deceleration you can find out variability is there. And so this is the overall impression is non-reassuring, and in this cases, further intervention was done. So thank you very much for the this talk on the CTG. So CTG is now important part of our obs and gynae practice, and we should use it with we should use the proper information, as well as our staff should be also trained about this CTG, and that is very important. How they should interpret and how they should timely inform you about your about the patient's condition as well as CTG. The CTG reporting, and in fact nowadays we have a e-CTG machines where you can get tracings on your phone. So all of you should get it. But again, always go for the CTG. Never do high risk pregnancy management at your hospital without CTG. This is for medical purpose also, and this is for proper patient's advantage also. So thank you very much, and thank you very much for patient hearing. Thank you.
Thank you, Dr. Bharti, and best wishes for the elections. Dr. Kiran Pandey, ma'am.
Thank you.
Dr. Kiran Pandey, ma'am, can you summarize?
Dr. Rajan Chauhan, I can also see, and now he is there, chairperson of session.
Yeah, hello, thank you.
Yeah, welcome,
Madam,
Dr. Rajan. UPCOG.
Dr. Bharti has presented very well CTG, and it was an eye-opener for us in rural area. Thank you, Dr. Bharti. It was an excellent presentation. Especially, you talked about intrapartum also, and adjuvant is always there.
ट्रैवल करने लग रहा है उनका इंटरनेट इशू आ रहा है ना
Yes.
I think it's disconnected.
और चेयरपर्सन थे सेशन के और चेयरपर्सन थे हमारे सेशन के डॉक्टर
किरण पांडे
अर्चना है
मैम
डॉक्टर राजेंद्र है डॉक्टर किरण मैडम आए हैं कि दिख नहीं रहे मुझे डॉक्टर अर्चना यू कैन कमेंट यू कैन कंक्लूड
you are
of knowledge. Thank you, and all best wishes to you for your next endeavor of becoming vice president from our society. Thank you, Dr. Snell.
Thank you, everyone. Thank you.
Best wishes.
Thank you, sir. Thank you.
Yes.
Dr. Sneha ma'am.
Thank you, sir. Thank you for joining as well. Yeah, even though you are traveling, and in spite of the network issues, you have joined to wish all of us the best. And of course, we are very happy to have your comments as well. Thank you so much.
Thank you. Best wishes once more, madam. Thank you. Best wishes.
Thank you. So, Bharti, that was excellent as always. And I thank all of you. I thank the chairpersons also. We can go ahead, Dr. Pragat. We can go ahead with the panel.
Yes, Dr. Archana Rathore, we have done last time labor monitoring. It was something extra from that.
Yes, yes, definitely, definitely. And this is the topic which we discuss again and again and again. We will always what I say, we will recall and apply it in our day-to-day practice.
Yes.
Yes, ma'am. Yeah. And
Okay.
all the very best. We are always there with you, madam. And we
Thank
wish
you.
good luck for your election.
Thank you. Thank you. Thank you, Dr. Sneha. Thank you. And now come next session, please to continue.
Now I invite Dr. Nutan to conduct the third session.
Yes, thank you, Dr. Bharti, for such an excellent presentation on echocardiography. I think we are coming to the third phase of our academic meet, and I would now like to invite Dr. Sneha Buhar to come take over for the panel discussion. For this, I would also like to invite our experts. Both our experts are here. Yeah,
Go ahead. Keep on introducing. They will.
Yeah.
Here they will.
Please, Dr. Sneha, first, please take over the session.
Introduce the panelists.
Experts and yeah. Now I would like to also introduce our experts. Dr. Richa Singh is there. Can we have the CV for her? Yes. Dr. Richa Singh, who is the president of Agra Obs and Gynae Society, and who is very been dynamically involved in the previous just gone UPCOG. And our next CV is, can you have a next CV also, please? We have Dr. Sadhna Jaiswal, who is the senior consultant of the Apollo Cradle Hospital in Greater Noida, and is also the president of the Greater Noida of OBGY Society. Again, the next CV, please. We have with us Dr. Kanchan Sharma, who is has been the chairperson of the NCD committee FOXY, and she has also been the secretary for the Kanpur Obs and Gynae Society 2021-23 conference. We welcome all the three experts for this. Now, can I have the CV
Dr. Richa Singh is not here. I can see Dr. Kanchan Sharma. Welcome, dear Kanchan.
Yeah,
Dr.
thank you,
Kanchan Sharma,
thank you, best
welcome as
wishes.
expert.
Thank you, best wishes.
Yes, Dr. Kanchan Sharma.
Thank you, my dear. Go ahead.
Yeah, and I would also like to have the CV of Dr. Dear Sneha ma'am also now. I think it's always a pleasure to read her CV. She has been tirelessly working for the FOXY as the FOXY Breast Committee chairperson from 2019 to 2021, and she's also been the GCM ICOG Suffolk Working Committee member and AMOGs chair for Medical Disorders Committee in 2024, and also the founder president of Vidarbha Isopark. She has also lots of awards to her to honor her, and she's also had International MS Signature Award for phenomenal leadership, which she obviously has shown in last couple of years. Asia CGC Award in 2021, Dr. S.N. Malhotra Individual National Award, Dr. Duru Shah is Distinguished Community Service National Individual Award.
Thank
and,
you. Thank
and
you.
all
Thank
of
you, my
these
dear.
awards, I'll just conclude by saying that she has been very actively involved in the rural healthcare also. So I once again welcome our dear Dr. Sneha ma'am. Ma'am, please take over the panel discussion.
Thank you so much. Thank you. Can we have the panelist CV? Or I think I will just go ahead. I'll share my screen and introduce my dear friends, my panelists. So I'll just go to the first slide. Yeah. So can you all see my presentation? Yeah. Hello.
Yes, ma'am.
Yeah.
It's
So
yes,
we have already welcomed our dear experts, and now this is time to welcome Dr. Shehla. Hi, Shehla. Dr. Shehla is such a young, dynamic friend and a great academician from Noida, I would say, not Bareilly now. Dr. Richa Agarwal, Dr. Neelam from Hapur, Dr. Neha Tyagi. I would request all of you to please put on your video. Yeah. So, hi. Nice to see all of you. Dr. Neha Tagli from Hapur. And hi. Anju Sharma from Agrawal. Hi, Dr. Anju. Dr. Amrita Raul from Palghar. Welcome, Dr. Amrita. Dr. Kalpana Barapatre from Palghar. Dr. Vidya Chaudhary from my own city, Yavatmal. Hi, Vidya. Dr. Neelam Singh from Agra. So we have two Neelam Singhs in the panel. Okay. So Dr. Seema Dwivedi, my dear friend from Kanpur. Hi. So without much ado, I would like to start with panel discussions. Friends, childbirth is the sentinel event in the life of a woman and a family as well. All of you know that it is intensely emotional as well as intensely physical. It's not as easy as it is shown in the movies, one, two, three pushes, and the baby is delivered and everything is fine. Even whether you are a senior practicing obstetrician or an academician in the medical college, or you are a trainee obstetrician, the dilemma always exists in the management of labor. As even today, the textbook of obstetrics say that normal labor and normal delivery is a retrospective diagnosis. At any point of time, things can go wrong. So action will depend on whether you are the protagonist of active management of labor or and the timely and appropriate intervention, or you are the follower of the masterly inactivity and the watchful expectancy. Whatever may be your way of managing, my dear, our aim should be to deliver a healthy baby from a healthy mother, and it should be an emotionally fulfilling experience for the mother. So, with this brief introduction, I would just like to go ahead straightway to the clinical, very simple, practical case scenarios. So, Shehla, do we have Shehla? I could see her some time ago.
Yes, ma'am.
Yes, yes. So, I want to see your beautiful face, my dear. Where are you?
I'm here, ma'am.
Yeah, so good evening. We have this Primi Gravida, 37 weeks. She comes to you in early labor. Her vitals are normal contractions. She has 25 seconds every 4 minutes, moderate contractions. Her head is, the fetal head is floating. Fetal heart sounds 140 per minute. They're good and, regular, but they suddenly drop in fetal heart sounds. So what is your diagnosis clinically from this history? How would you go ahead with the diagnosis and the management?
Okay, ma'am. Thank you so much, first and foremost, ma'am, and best wishes for your election.
Thank you.
The clinical diagnosis with a sudden drop in fetal heart rate and free floating head seems to be cord prolapse. Other differential that must be kept in mind is abruptio placentae.
Right. But then what would be the differentiating feature if you say abruptio? Because the contractions here are 25 seconds every 4 minutes. So on this aspect, yeah.
So, ma'am, the most important clinical feature to to differentiate between the two clinical scenarios is presence of bleeding. If it is visible, then we may presume that it is a case of abruptio placentae. Secondly, if patient is hypertensive, and yes, if there is a tonic contraction of uterus or localized tenderness in the uterus, then it may be a case of abruptio placentae. But given the history and the clinical scenario that she has free floating head, moderate contraction, there must be sudden push and cord presentation and prolapse should be ruled out.
Right. So perfect. So you have clarified your differential diagnosis that she is not hypertensive. She doesn't have tonic uterine contractions. She doesn't have tender uterus, and fetal heart is 140 per minute. They were till now they were apparently normal, and there is a sudden dip. So that itself gives you a very single diagnosis of maybe query. Even still now it is query cord prolapse. How would you come to the definite diagnosis on examination?
Okay, first of all, a visible external examination. If cord is loosely hanging out, then definitely it's cord prolapse. Then we may do a gentle PV examination. If the cord is not hanging out, then we may do a gentle PV examination and see dilatation and presenting
Sheila,
participation
I
can
would like to
confirm.
interrupt you here. Before looking for the cord, would you like to have some other things to be looked for? Whether there is any
The
spontaneous
rupture of
rupture of
membrane.
membrane. Yes,
Yeah.
perfect. Okay,
So
so you
yes.
ask the patient to either you can see the pool of, a fresh gush of liquor coming out, or you will just, ask the patient to cough. And then you can, if you feel the cord pulsations or you can see the cord, definitely the diagnosis is confirmed. But sometimes it can happen that you don't see the cord and you don't feel the cord. Okay. In spite of that, there is a sudden deep in fetal heart rate. Then how would be your diagnosis, and then how do you confirm that?
Okay, we can do ultras. First of all, clinical examination, PV examination, feeling for cord pulsation, looking her into her antenatal history. If there was presence of cord tunic presentation, then this may help us in making a diagnosis of cord prolapse, maybe an
Okay.
occult one also.
Okay, but then I would take you to this point little later. When you examine, there is a fresh gush of fluid. Yeah, there is rupture of membrane. You don't feel the cord anywhere. Now you go to the ultrasonography. You find, uh, but the diagnosis is still cord prolapse. Okay, so that is what is something called as occult cord prolapse. Okay, the cord has just descended down in between the fetal presenting part and the myometrium, right, or the uterus. Correct. So, as you said, if it was a unique presentation, I mean, is it that we could have allowed her to go into labor?
Not really, ma'am.
Sure.
If
What
you
is
ask me very practically, no.
Even theoretically, no. Dr. Richa,
Yes,
yeah.
ma'am.
So I would ask you that what are the situations or what are the predisposing factors that lead to cord prolapse?
Ma'am, like obstetrics, as you said, it's full of emergencies and anything can happen at any time. So we as obstetricians have to be always alert. And the most important thing is we anticipate that we are expecting a deviation in our plan. So we
Okay.
will expect a deviation of cord prolapse whenever the head will not fix. Then we are expecting that something can come from the sides. That we will expect when the maybe there is a malpresentation, when the
Okay.
head is not down or the head is small, like a premature baby, or polyhydramnios when the head is not able to fix.
Right.
Multifetal gestation, maybe the first baby will deliver, but with the second baby, we might face a problem.
Yes.
Things like that. And sometimes, if there is a maybe a spontaneous rupture or an artificial rupture with a floating head,
Yeah.
there is always a risk of cord prolapse.
Okay. So we will just go ahead with this. Dr. Neelam, can you
Yes,
just throw
ma'am.
a light on this management, that how would you go ahead with the management? This is a short case actually. We should not take so
Yes, ma'am, definitely. For the management, my first and foremost rule is if the baby is in the viable condition, then delivery at the earliest.
Right.
By the whatever mode, and if close the door.
Right. So for
If
this
we are
patient,
expecting delivery earliest, then we will do it by whatever the mode is possible. बाहर जाओ बेटी, बाहर जाओ.
right.
And by the time we are expecting that cesarean is going to take, we are doing the preparation. We should keep the patient in head low position, and
Okay.
we will try to push up the presenting part upwards so that the pressure on the cord can be a little bit decreased.
Okay.
And ma'am, by the time we are preparing for the cesarean section, we always try to keep the mind when patient is can have the cord presentation or cord prolapse. We can advise them early admission also. They are
We
in
talk about
transfer
it later
flight
on. See,
and
Dr. Neelam,
pre-presentation.
yeah, we are talking about the management of this particular patient. It is very simple because you can feel the cord pulsation, the fetus is alive, and you
Yes.
have to deliver these fetus by whatever modality at the earliest. So definitely you have to keep all the preparations ready for cesarean section. But meanwhile, you turn on left side, left lateral side. I think somebody is making noise. So, oh,
It's okay, ma'am. It's okay.
yeah. So, we have to give the patient on left lateral position, give adequate oxygenation, maybe knee chest position.
Definitely.
Okay, so that is how you have to manage till the time you get ready for cesarean section. But If at all your patient is in active labor and she is pushing, well and good, you can deliver maybe by the instrumental delivery. Okay. But if not so, you have to go ahead with cesarean section at the earliest. You may say class 1 cesarean or crash season, whatever you want to say. But is there any role of tocolytics or amnioinfusion? I would just ask you, Dr. Neelam. Very specifically, is there any role of tocolytics or amnioinfusion?
We are having the patient in early labor and we are in condition not able to do the cesarean or shifting the patient, then we can use tocolytics for some time for the shifting the patient.
Any experience you have? Have
Ma'am,
you? Yes.
ma'am, definitely never, ma'am. I have not used.
So I think the things which do not have any evidence should not
Yes,
be recommended and should not be discussed also. So
Yes.
I would say from this platform, a strict no to tocolytics. The evidence says strict no to tocolytics, and of course no rule. Don't waste in time in anything rather for that matter. Just go ahead with the operative delivery by whatever modality it is possible. So basically, now we come to the conclusion that if the baby is alive, you deliver the baby by cesarean section or instrumentation, whatever is possible. Now we go retrospectively that if at all, suppose you have cord presentation, how do you diagnose it and how do you manage it? We can go ahead with the next panelist, I think. What is the recommendation, RCG guidelines? Can we have from the Neelam, other Neelam?
Yes.
Neelam Singh. Yes, please go ahead. Neelam Singh from Agra. Dr. Seema Dwivedi. Seema, Dr. Seema, you can unmute yourself.
Yes, ma'am.
Yeah. So, what is the recommendation?
Recommendations are ideally ARMs should be avoided if the presenting part is high up and non-engaged, and if the ARM is not indicated. Usually we go for ARM, ma'am, especially in our setup when there is severe distress and the head has descended and the membranes are bulging. Otherwise, it is better to be avoided. And it is preferable if the patient is identified at risk. That is when an ultrasound is done in each of the patient, and when we see any cord coming before the presenting part, it is the patient should be labeled as very high risk, and timely cesarean should be done.
So, Dr. Kanchan, I would ask you to make the last comment and then we conclude this case. Dr. Kanchan Sharma, do we have Dr. Kanchan? Okay, so I would just conclude this case by saying, see, the moment you have either transverse lie, oblique lie, or maybe multipetal gestation or breech, or maybe even the floating head, these are the women, if you identify by 36 to 37 weeks, these are the women who you should not allow them to go into labor unless you confirm that, there is no cord presentation, or it is called as phunic presentation. If at all you do the ultrasound at 36 to 37 weeks or at labor room admission and you find that, the phunic presentation or cord presentation is there, don't allow these women to go into active labor. Don't go for artificial rupture of membranes and go straightway for cesarean section. That is what is the RCOG guideline. Okay? Is it clear? Do all of you agree to this?
Yes, ma'am.
Yes, ma'am, definitely.
Can we see all the panelists, please?
Yes, ma'am.
Yes,
ma'am,
Dr.
definitely.
Neha.
Yes, ma'am. Thank you.
We come to the next case now, Dr. Neha. We have 28-year-old young lady. She's had 3 spontaneous abortions. This is the 4th pregnancy. 39 weeks she is in labor now. She delivers a full-term baby girl. Placenta is not expelled for 45 minutes, even after baby's delivery. Okay. So what is your clinical diagnosis from the history?
So, ma'am, typically the placenta delivers within 5 to 10 minutes maximum after delivery of the baby. We still 30 minutes, and if it fails to expel even after 30 minutes, it's known as retained placenta. So, retained placenta can be a trapped placenta when there is atonic uterus and the placenta is still not adhered, but it is still not detached from the
Okay.
uterine lining. Or it can be trapped due to closure of the os due to premature uterotonics that have been given, and it is
Right.
not delivered out. Or
Right.
it can be accreta spectrum,
Okay.
especially in
So
this
how will you
case.
manage this? This is all theoretical. How will you
Yes,
manage
yes.
this patient?
So, ma'am, this patient already 45 minutes, so we have to act promptly because it carries a high risk of mortality up to 10%, and we have to communicate to the relatives that we have to deliver the placenta in an OT, call for help, and take the patient to OT and
Yeah.
under
So,
IV.
so before taking to operation theater, would you like to do something which is very practical?
First of all, we have to check for the tone of the uterus. If the tone
Yeah.
is not good, we have to give good uterotonics in the form of oxytocin or ergometrin if need be, and also give a fundal
Anything
massage.
else?
Try to control.
Anything else? Anything
Ma'am,
else?
ma'am,
Ma'am,
we
control.
we
Yes.
at our center, we prefer doing an ultrasound, especially to
Yes.
exclude ectoplasm.
Anything
Accreta
else?
we have to rule out. If we have to see whether there is any hypoechoic layer is supposed to be there between the
Yes.
uterus and the
Yes.
placenta. If that is lagging, especially 3 abortion, maybe she has undergone DNC, maybe there's a scarring in the uterus which is called adherent placenta or accreta. So that has to be ruled out and accordingly counsel to the patient that she may require laparotomy and hysterectomy if
Okay.
there is bleeding.
Okay.
Then
So most of the times it happens, that if at all you have a retained placenta, you just
yeah,
catheterize the bladder, you
right,
just put in oxytocin, and most of the times it is, expelled out.
expelled
This is
out.
why, because sometimes even the full bladder can lead to atonicity of the uterus, right? And if
True.
the uterus is atonic, maybe the placenta is not getting separated. Once you give her effective oxytocin, it can get
Can
separated.
deliver out.
Maybe you can go ahead with simple controlled cord traction once again, and that will be separated. But then suppose even after all these maneuvers or manipulations, it is not getting delivered and the patient is not bleeding. The simple thing is, when should you go ahead with the control cord traction? Let me ask you rather, when should you go ahead for the manual removal of placenta or control cord traction in such situations?
Ma'am, once we have ensured that the bladder is empty, the tone is good, and we
That
wait
is
for
okay. That is okay. But whenever you have the signs of placental separation, suppose if you have little lengthening of the cord,
permanent lengthening of
little
the cord and
separation and
gush
fresh
of
gush,
blood.
then only you should go.
Yes.
Otherwise, if at all you don't have any signs of placental separation, you should go ahead for ultrasonography and take a diagnosis documentation saying that there is no morbidly adherent
Morbid.
placenta, right?
Right.
Otherwise, should not go ahead with manual removal of placenta because that can lead to catastrophe, like
Torrential bleeding. Yeah.
severe bleeding. Okay, so now that you have done all the maneuvers and still she is not bleeding and there are no signs of separations, now you tell me, how would you go ahead?
Once, if it is ruled out on ultrasound that there is no evidence of accreta, we can take her in OT and under anesthesia, we can do manual removal of placenta.
How do you
By
do that?
Ma'am, we can, first of all, we need long gloves, sterile gloves, which cover our forearm. And so we have, with one hand, we have to reach and make a cleavage plane between the placenta tissue and the uterine lining and try to detach it from the uterus. And while with the other hand, we are giving the controlled traction in order to prevent the inversion of the uterus because it has been atonic for quite some time. And so we try to, as long like how much ever possible, we try to detach the plane and try to gently pull out the placental tissue and also look at the placenta after we have delivered it out, whether any lobes are remaining, and then make sure that the entire cavity is empty.
Okay, what
That is.
else? Once you remove the placenta, you will give the oxytocin.
Yeah, oxytocin has to have to be given either 20 units of 20 units of oxytocin in RL, and we have to give it at the drop of 60 to 100 drops per minute, depending on, we can escalate it depending on the response. Also, if that doesn't work, we can add on ergometrin if the patient is not PIH, and also carboprost 250 mg microgram IM can be given if the patient is not a case of asthma. that all can be taken off.
Okay, so once you remove the placenta, you have to inspect both the fetal and the maternal aspects. And why is that so? Maternal aspect, you said maybe some lobe or placental tissue is missing. Why you want to see for the fetal aspect?
Ma'am, I didn't get your question.
You have removed the, see, you're trying to create a cleavage between the myometrium and the placenta, right? Page of placenta. You have separated it from all side, and then you are turning it like a page of a book. And then at the same time, you are trying to remove it with the same hand. On the other hand is on the abdomen. It is supporting the fundus and pushing it upwards. Okay. So once you remove the placenta, you are inspecting. You said that maybe the maternal aspect, there may be some missing placental tissue or lobe. But fetal aspect, why do you want to inspect? Because there can be, what is called as succensurate
lobe of placenta. Yeah, I was about to say.
If the membranes and the vessels are in continuation, you know that there is something still more remaining inside. That needs to be removed. Okay.
Yes, ma'am. Ideally, we should also have, if at all an ultrasound is diagnosed antenatally, we should make a note at the time of delivery that this particular patient has a succensurate lobe.
Yes. So I think placenta accreta, we will discuss it little later if I have a case. Otherwise, we'll go ahead. Okay. So Dr. Anju, we come to you now. We have this second gravida para 1 with 36 weeks pregnancy. She has had previous normal delivery. Okay. Dr. Anju?
Yes, ma'am.
Normal vaginal delivery. Now her vitals are normal. Fetal heart is 150 per minute. Cervix fully dilated, fully effaced. Breech presentation. To your surprise, she's pushing. Station is +1. What will be your way of management and how do you justify this? Second gravida, previous one vaginal delivery.
Ma'am, as this case comes in a labor, and she's her vitals are normal, fetal heart is normal, cervix is dilated, then what we need a recent ultrasound that is missing, how to judge the fetal weight. So I want to
Anju, I would stop you here. I would interrupt you here. She's pushing, fully dilated, breech.
Yes.
Station is +1. There is no question of even thinking.
Okay, ma'am. We will go for
yes.
Ma'am, we will go for assisted vaginal delivery.
Just imagine that this patient has come. She's right in front of you now. She's pushing a bridge. What will you do?
Ma'am, we will manage vaginally and we'll put IV line. We'll take the consent and we'll give liberal episiotomy and
what consent you want to take for her? What consent you want to take for her?
Consent we have to inform about the normal vaginal delivery side effects and if she may need if there is a
arrest. It will not be normal. It will not be normal. She's breech presentation. If it is
abdomen, yeah, ma'am. We will take the consent regarding the pros and cons of vaginal delivery and the cesarean section.
Perfect.
Yeah. And we will look for other risk factor if there are or their risk factor are there or not. And there should be an experienced obstetrician to dealing such patients. And there should be
now she's already there in front of you, so you can't think about you can't think. So that is what I said. First and foremost thing is to call for help. Call for help. By the time, see, your one team will be explaining the patient and relatives that, oh my God, this is breech. She's fully dilated, fully dilated and breech at +1. We don't know because now the patient has come to us in this situation. So we have to either try and deliver her vaginally if she delivers fast, but if no, station plus
everything,
may give you some time, and by the time you may have to make arrangement for operation theater, and if you may be lucky enough that by the time you think so much and take the consent, the breech comes out and the baby is delivered and things are happy. That is called a spontaneous breech vaginal delivery. Okay. But if she just pushes the breech and then you have to deliver, then how will you go ahead? What is
called assist till the level of umbilicus. We will deliver the baby, and after that we will assist for the removal of hands and after coming head.
Delivery, yes.
Yes, ma'am.
So how? Suppose your baby has come up only up to umbilicus. Now what will you do?
And we will not ask to push. We'll wait and take out the arms, and we will take out the legs first, and then rotate the shoulder. Always keep the shoulder anterior.
The
and
back.
take out,
The
yeah,
back anterior.
back
Shoulders
anterior.
will be
Sorry,
anterior.
ma'am, back anterior, and remove one shoulder. If it is not coming, then we'll rotate the shoulder and take out the posterior shoulder first, then take out the anterior shoulder.
Okay, but then suppose your patient is pushing, the baby is only up to the umbilicus first. Now you have to ask her for continuous pushing, definitely, but at the same time, let the baby hang by its own weight,
Yes,
right?
yes.
And just maintain the back anteriorly. Okay.
No, not be in hurry.
No unnecessary pulling,
No unnecessary pulling.
Yeah.
And see
Okay.
for cord pulsation also.
That we don't have to see. We have to deliver the baby as fast as possible.
Yes.
Ask your assistant to hold the baby, just wrap it. Okay. Now
Yes.
you tell me, how will you, suppose the hands are not like down like this, they are knuckle hand, up above the head like this. Then how would you deliver suppose the legs, we talk about the legs, your lower limbs are still inside and the head, legs are extended. Then how do you deliver the baby?
We can catch hold the foot link of the patient and
Foot only is not there. No, it is high up, extended.
When we can put a finger inside the knee and compress it, and then bring out one leg one by one.
Okay, what is it called as?
I just forgot. I just forgot.
No worries. That is not necessary. You are a practicing obstetrician or a clinician. For you, practical management is necessary. Name is not necessary, but it is called as Pinard's maneuver.
That's maneuver. Yes, ma'am.
Like
Pinard's
maneuver. So you tap and the popliteal fossa, give a jerk so that the leg bends, flexes, and you can hold the ankle. Now you hold the ankle, deliver both the ankles, and deliver the baby. So up to maybe scapula it is seen. Now how do you deliver the shoulders? You tell me.
So again, we will keep the back anterior, and which shoulder is below, we will take out first posterior shoulder and then take out the anterior shoulder.
Okay. So you may have to, what is called as rotate the shoulders like this. Okay. Why? Because the posterior shoulder is at a little lower level, but the anterior is at a higher level. That gets stuck. So that is why you deliver the posterior first, and then you turn the baby like this in 180, half circle. Okay. Okay. So now, yeah. So how do you deliver the after coming head?
For after coming head, if it is flex, we will maintain the flexion, and we will put the baby over the abdomen sometime, and then put a finger inside the chin, mouth of the baby, and flex the head, maintaining the flexion of the head.
Okay. I think we can have it from Seema now.
Yeah.
Dr. Seema, the delivery of the after coming head from your side.
Yes, ma'am. The after coming head, the main aim is to maintain the proper flexion of the head. And we have to maintain pubic pressure from above to maintain the flexion of the head. And while doing, we have three modes of delivering the fetal head, either by Burns-Marshall or by the FNV, that is Marshall-Smellu-Weight method, or by forceps application, depending upon the situation of the condition of the case.
Okay.
And most of the time in my clinical practice, I have gone for Burns-Marshall technique, whether it is abdominal or in cesarean. We are very comfortable with this technique, in which definitely in which we hold the foot of both the foot of the baby.
Both the ankles, and turn the baby on the mother's abdomen through a wide circle, right?
Yes,
okay.
Yes.
So that is Burns-Marshall. What is Morris-Smelly-White?
Ma'am, this is basically used if the head is deflexed, and most commonly now used in Western area also. That is, if the baby is held on the left forearm, the whole body of the baby is held, and we keep our finger and the middle index finger and the middle finger on the maxilla of the baby to maintain the flexion of the head, and by our right hand has to be on the shoulder of the baby. That is our index finger and the ring finger and the small finger. They both are on the respective shoulders, with the middle finger pressing on the occiput to maintain the flexion of the head.
Yes. So this way, This will maintain the flexion, and this is your shoulder traction. Shoulder traction.
Shoulder traction, maintaining the flexion, we deliver the baby.
Okay. Suppose it doesn't come, then you have only one option, that is forceps. Have you ever delivered? Which forceps do you use? And what is the difference in the technique?
Didn't require the forceps. But if it doesn't come and there is fetal distress, we have a time limit in which we have to deliver the baby. Then definitely we require forceps. But the prerequisite is that it cannot be applied in very high head. So that we have to have the head approachable, and for that the whole baby Piper's forceps are ideal, but they are not available everywhere, and they have specific low curve which can be easily applied, and the trauma is not much to the baby and mother.
So for this, what you have to do is that your assistant has to hold the whole of the baby, and you have to literally sit down and apply the forceps and deliver the baby. Your assistant has to hold the baby. You have to actually kneel down or sit down and then apply the Piper's forceps, because that's a low forceps with pelvic curve. So actually you have to sit down and deliver the baby. That's only the head you need to deliver. It's not downwards, forwards, and upwards. Okay, it's only downwards like that. Right. So I think we have delivered the breach very well. So we go ahead with the next case now. We have this Dr. Amrita. Amrita, we have lots of interesting cases. We just go ahead, and I think all of us can participate in the discussion. So do we have Dr. Amrita?
Yes, ma'am. Yes, I'm there.
Yes. So we have this second gravida, 34-year-old. She's having gestational diabetes. She comes to you in labor at 37 weeks. When you examine per-abdominally, 36 weeks, cephalic presentation, 3/5 head palpable, fetal heart good. She was in early labor, but now she progresses very well. Within next 6 hours, she, delivers. Progresses well, and after 20 minutes of full dilatation, the head is delivered, but the shoulders are stuck, and now further delivery is possible. What is your clinical diagnosis, and how would you go ahead? Amrita.
Madam, this is a case of shoulder dystocia.
Right.
It is a obstetric emergency, basically. So basically the anterior shoulder becomes lodged behind the maternal pubic symphysis.
Right.
So the head is delivered and the shoulder will get stuck.
So how to go ahead?
So first is call for help. And then second is you put pressures, supra pubic pressure has to be applied. Then hyperflexion of the knees.
Yeah. So how does it help you? First and foremost, you said yes, call for help, call your senior colleagues, call your anesthetists, call your neonatologist, because this is going to be a difficult delivery and the baby will be distressed.
And I would need a big episiotomy. A big Then
but you will give suprapubic pressure first, or you will make the patient hyperflex her lower limbs?
First hyperflex. I ask the sisters to assist and to make robots maneuver.
How does hyperflexion or Mac Roberts maneuver help you to deliver this baby? How does it help you? When you hyperflex, that means you flex the thighs on the abdomen.
Yes.
Okay.
Yes.
So what does it do to the birth canal?
It causes alignment of the pelvis and the spine.
Yeah.
So that the head slides down.
Right. And also the epidiameter, it straightens the birth canal, and also the epidiameter is increased.
Diameter increases.
Okay. Now you can see here the sister is giving suprapubic pressure, and you are saying hyperflexion of the lower limbs and suprapubic pressure. Mind well, suprapubic, absolutely no two fundal pressure here. That will worsen the situation. Okay. Yes. Suprapubic pressure. So where do you give the suprapubic pressure exactly? Right side, left side, above, below, where? It is same on this side. If you carefully look at this picture.
Then just above the pubic symphysis.
That is okay, but right side or left side? Or where? See, you can see the head of the baby. You can see the occiput. Okay. So on the side of the occiput, If occiput is on the left side, you have to give suprapubic pressure on the left side. Okay, so that the left shoulder is pushed towards right, so that the bis acromial diameter, the diameter between the two acromions, the shoulders, become less. Okay, and then the shoulder is dislodged from there, and then it comes down. This is the easiest methods. Okay, 90% of these patients, they deliver like this, by this maneuver. Okay, so shoulder dystocia, don't get scared. Hyperflexion of the lower limbs and quick suprapubic pressure on the side of the occiput. Correct? The head is outside only. You can make out the occiput is on left side, right? Suppose you cannot deliver the shoulders by this method. Then what is the next method? What is the next maneuver?
The wood corkscrew maneuver, in which I will rotate
the and how is that?
Deliver the posterior.
Yes.
After rotation, I will deliver the posterior shoulder first.
So from where to where you want to rotate? I have told you in the previous case, like your shoulder, that was for breech. That was for even, like this, you rotate. But there the shoulders are outside. Here the shoulders are stuck, but so you put your fingers inside, put your fingers inside from here and you turn half circle. Okay, so the anterior becomes posterior and posterior becomes anterior. Okay, half circle. See this, you can see this circle, half circle here. Okay, suppose even if that also doesn't, then what is the next maneuver? I'm sorry. Any problem? Can you see my screen? There is some problem with the net.
Yes, madam.
Yeah. Okay. So absolutely no to fundal pressure. And if even this doesn't help, then what is called as, you have to actually deliver the posterior shoulder first, go inside the vagina, deliver the posterior shoulder, and then you deliver the anterior shoulder. Okay. So that is how it is. Only thing is, first and foremost, even if the moment you see that the baby is not coming out, you feel that, oh my God, the baby is going to die, or maybe the baby is going to become very severely asphyxiated. So you become so panicked so that you stop thinking. Okay, so rather than that, don't become panicked. See that you don't unnecessarily pull the baby, no fundal pressure at all. Just follow the maneuvers sequentially and go ahead. Okay, that is what is the message from this case.
Madam, I want to ask you that rolling the patient on all fours, can it help?
Yes, that is what knee chest position that is called as. Okay, so that is also one more maneuver. In fact, in Western countries, they have started delivering the patient routinely in four limbs or maybe in a sitting position. Some of the medical colleges also are running these trials and they are coming up with the data. Okay. So we go ahead with this next interesting case now, Dr. Kalpana. We have this 37 years, second previous cesarean section. She presented with labor pains, contractions 2 to 3 in 10 minutes, lasting for 30 to 40 seconds. That means good uterine contraction, no scar tenderness, but the cervix was 6 centimeter dilated, fully effaced, vertex is station 0. Then at full dilatation, suddenly she gets, severe bradycardia. And when the vertex is at +1, this fresh bleeding, no uterine contractions. When you catheterize the bladder, the baby is not coming down. So when you catheterize the bladder, it is blood thin. What is your diagnosis and how would you go ahead with the management? Dr. Kalpana, do we have Dr. Kalpana? Yes. Please unmute. I will unmute for you. Unmute, please. Dr. Kalpana, click on the mic. Yes, click on the mic. Yes.
Am I audible?
Yes. Go ahead.
Okay. Madam, because there is bradycardia, it can be a case of cord prolapse or cord round the neck or abruptio placentae with short cord. Or there is because after catheterization there is blood thin urine. The diagnosis goes more in favor of a scar rupture or a scar dehiscence or uterine rupture.
Right. Yeah. So because here you are giving differential diagnosis, but then because she has bleeding, fresh bleeding, there's no question of cord prolapse, right? And there's no, so once you have hematuria and bleeding, it's mainly of a scar rupture or uterine rupture. So how would you go ahead with the management now? You have this patient stuck up here at almost full dilatation, vertex is +1, but she started getting hematuria and fresh gush of bleeding. Would you still continue to deliver her vaginally, or would you take her
It's
for
a
cesarean
uterine rupture
section?
is a life-threatening complication, and it is a big risk to the mother as well as the child. So we have to immediately deliver the baby. We can, if the head is fully engaged and it, cervix is fully dilated and effaced, then we can go for a vaginal delivery, or else we can make preparations at the same time for a emergency laparotomy with hysterectomy. We can take the consent. We have to
Because, you
explain
know,
the patient
Kalpana,
about the
even
condition.
there's no, I would just interrupt you here. There's
Possibility of
no question of
vaginal
going
delivery
ahead
is
with
difficult.
vaginal delivery.
Yeah, it's difficult.
Because
It's
once you
better to go for a
suspect,
laparotomy and hysterectomy.
it will be, you know, go to extent. Right, right. So it will be for cesarean section or laparotomy, whatever you want to say, but it will be emergency cesarean section, right?
Yeah.
Now, yeah. So yeah. So that tell me, because you know, vaginally, even if you deliver, you will not be able to manage it further. You have to open up the
No, it's
patient,
not
right?
possible to
And
go
when
for
you
a vaginal delivery. But madam, till the time we are preparing for the laparotomy and hysterectomy, by chance, if it is fully dilated, we can first deliver the baby to save it and then go for a
if
laparotomy.
it
That
is
also can be done.
automatically coming, yes,
Automatically it is delivered.
Agree.
Yeah.
We
If
can save
the
the
baby is
baby.
getting delivered, if the baby is getting delivered automatically without much manipulations, definitely yes. But then the very fact that the scar has ruptured, that means there was some
We have
resistance
to
from.
go for a laparotomy.
Yes. Now, you tell me, suppose whether it is always a hysterectomy, as you said, laparotomy and hysterectomy, whether it is always a hysterectomy or there is a delivery of the baby followed by repair of the rupture. What is your
Madam,
opinion
if
about this?
when we go for a laparotomy or a cesarean section, and if we see that it is a rupture or scar dehiscence or a clean cut scar, then we can go for a scar repair. But if it is extending into the upper segment or there is a broad ligament hematoma, then it is always better to go for a hysterectomy. And if the scar is repairable, then in the patient is ready for patient wants to continue for her future fertility issues if she's got, then we can go for a scar repair. But there is always a risk of scar rupture again in the next pregnancy, so it is always advised to go for a elective cesarean section in the next delivery.
Perfect. And this needs to be mentioned in the operation notes and needs to be explained to the patient and relatives very carefully, that how and when they should plan the next pregnancy. And if at all they plan the next pregnancy, they should go for elective cesarean section, maybe at around 37 to 38 weeks, before 38 weeks, I would say. So perfect. Now I would ask.
And ma'am, if there is a scar rupture and if the patient does not want to continue with her fertility, then we can go for a TL also.
As
but
it is
I don't
for this patient, 37-year-old, definitely if it is not salvageable, and you know, with the consent, what you call it as informed choice, given an informed choice that you do hysterectomy simultaneously, but then you have to weigh the risk and benefits also, because it's a major surgery, right? So,
and
Dr.
subtotal hysterectomy is better than a total hysterectomy to avoid injury to the ureters and bladder.
Okay. So
I would go for a subtotal.
Okay, accepted. So, Dr. Vidya, for this patient, she was a case of previous cesarean section. So, what are the other risk factors for uterine rupture?
Yes, uterine rupture, it's really a nightmare for any obstetrician. And nowadays, cesarean section is on high demand. So, whenever patient of previous scar comes in labor, your deal also start dhak.
Right.
So, many other, like any surgeries over uterus, like
removing myoma. Grand multiparity nowadays little bit low on side, but still we do get sometime. Then any unnoticed malpresentations and patient goes in labor like bro, shoulder, whatever. Then obstructed labor again with advanced intrapartum care or nice intrapartum care. Now we get less cases of obstructed labor, but sometimes we do get. Then prostaglandins and oxytocin, if used for augmentation with high doses, again, it may lead to
inadvertently, right?
Yeah.
Yes.
Then use of misoprostol. Nowadays, it's increased very much. So if it is used in high doses and in high parity patients, again, it is a risk for it. Then any oxytocin or rather injurious use of this Killen's forceps.
Rotational.
Like just rotational forceps, not applied properly, not applied at proper stage. It is also one of the aggravating factor for rupture.
But then I think you have just completed the list, but I would say that high forceps and rotational forceps, I don't think even last 3-4 decades we have seen or heard anybody. Maybe it's a rarity.
It's become obsolete. Yeah.
Mostly outlet.
Yes.
Yeah.
And of course, the previous cesarean section or hysterotomy, people go for vertical incision, maybe for some unknown reasons, not mentioning in the notes, operative notes, and not explaining to the patient. That's the highest risk, I would say. These are the patients who are very prone for going for uterine rupture. So very well explained, Dr. Vidya. I would just ask you once again that if at all you have such patients, how would you now for this patient? She was a case of previous seizure. How do you decide whether this patient should go for vaginal delivery or she should straightway go for cesarean section?
The indication of cesarean section, it matters here. Whether we should directly post her for elective or should give trial for labor. So selection of patient is very important.
Right. So you are very correct.
Duration also. Duration between two cesareans.
Correct. So basically, as you said, obstructed labor, when the lower uterine segment is very severely thinned out and you do cesarean section for that patient, that is also a patient who is not only the classical cesarean section, but obstructed labor with very thinned out myometrium. That is also a patient who is high risk for scar rupture for next time. And of course, the closure, which is, improper. The uterine suture, the suture has to be closed in 2 layers. There was a wave of suturing,
single layer.
closure, and people used to just hurriedly suture everything, and that because of this actually scar ruptures, scar ectopics, and all these things, problems. Even nowadays you see that scar dehiscence, and even in between the pregnancies you have ischemic collections and all those things.
I'm getting
lot of malformation also.
Isthmocele. I am dealing with mostly infertility. I'm getting lot of isthmocele. Recently, I did an isthmocele repair.
In fact, we are the proponent of double layer closure right from the beginning. So it should be ideally a double layer closure. It should be specifically with what is called as decidual exclusion. You just catch hold of the myometrium, leave behind the decidua, because if you include decidua, that will shed off, and then you have a guttering or thinning, weakening of the scar, and that is what leads to isthmocele. Maybe by the time I would just make a comment here. Of course, never go for locking. What you have learned 4 decades ago, 3.5 decades ago, that used to be locking. In fact, that is the worst thing to do. It has to be continuous, not locking.
Yes.
Not locking. Because any suture that is locking will lead to necrosis of the tissue and will interfere with the strength, right? So these are all the practical tips what we have to definitely remember. So these are the some cesarean sections which are done by we have to. So the take home message is, of course, Whenever you suspect such kind of emergency, call for help without wasting any time, without wasting any thought also. Whether you have a junior or a senior colleague, maybe experience. It may be senior experienced obstetrician or a junior who is well expertise, having a well expertise in that field. Definitely call for help. Keep the relatives informed from time to time. Make essential arrangement. Vigilant monitoring is very, very important. Timely and appropriate intervention and documentation. Whatever you do, communication, very important, and documentation. Documentation of the communication and communication of the documentation that we have already spoken to you. See this, we have got it written from you. That is very important to avoid all these medical legal issues. So friends, intelligent anticipation, skilled supervision, prompt detection, effective institution of therapy can, actually prevent the disastrous consequences. And of course, not to forget communication and documentation. So with this, I conclude the panel. If at all my expert is here, I would like to have the last word from her, Dr. Kanchan, if you are here. Otherwise, I thank all of you. Yes. Do we have
Madam,
Dr.
I would like to tell you one thing.
Please go ahead.
I and Vidya Korpe are from the same batch from JMC Nagpur.
Perfect. Yes. Good.
We are batchmates, 84 batch.
Yeah. I mean, so by now I should know that both of you are good friends and batchmates. So of course, Vidya is a very dear friend to me also. So that's the reason I keep calling friends everybody, because all of us are friends of everybody, and the world is so small that we are friends everywhere. So I just conclude this panel. I thank all of you.
Dr. Sneha, one question only to you also.
Please.
Any relation of suture material?
Yes.
Like for closing the.
So yes. So previously what we have learned and what we have practiced, even I have practiced till maybe 10 years earlier. We used to use chromic catgut #1 for closing the uterus. Okay. 10 years earlier, not within these 10 to 15 years, before 10 years, when what we have learned as a resident or PG student also, it was chromic catgut #1, and that was locking. But that I told you that over the period now it has been proven beyond doubt that no locking, because that leads to necrosis. But suture material, chromic catgut and Vicryl, there is a difference of strength, both are absorbable. But definitely chromic catgut has the period of absorption is only hardly 2 to 3 weeks, whereas the Vicryl has the period of absorption, that is, it is a delayed absorbable suture, so at least 2 to 3 months. If you go to the physiology, the tensile strength of any wound, if you consider, that takes at least 3 months to complete wound healing. And that is why you want to have a suture material which will hold the two edges together till the complete healing process is done. That is, the process of healing is complete, and that is 3 months. That's the only scientific explanation of switching over from chromic catgut to Vicryl, which I am doing last 10 years. So otherwise, chromic catgut #1 was our favorite suture material as well. But whenever you have a scientific evidence and whenever you have better option, I think it's good that we change over to the better option. So that is what is from my side.
Ma'am, I think
it was an excellent webinar.
Rajendra sir has to say.
Yeah, we can hear his views also. Thank you for being there till the end, Dr. Rajendra Chauhan.
Yes, sir.
I want to comment one thing about Dr. Snehal Boyar, madam, that my best wishes from our society to you. And I wanted to tell one thing, that whenever we have met, I have learned something new from you. And thank you very much for that. You are really a great teacher, madam.
Sir,
thank you
so much. I'm just trying to do my bit, and I'm happy that if you are much more experienced than me, but whatever little experience I have, that is almost now 33 years, I want to share with people who because they will also improve on their part, and it will be helpful for them. Even though whatever mistakes we have made, I think people will learn from it. I think that's all I'm trying to do.
It was a very fruitful discussion, ma'am. Very fruitful discussion.
Yeah.
Thank you so much.
Thank you, my dear. Thank you so much, all of
Thank
you.
you,
Once
and wish you
again.
all the
Thank you,
best.
madam. Thank you, Sneha, madam, and all the best to you.
Thank you, dear.
Thank you,
Thank you so much.
Thank you to all the panelists, and
Thank you, Nutan ma'am.
thank you for all
Thank you,
your
Nutan.
interest and cooperation. Dr. Rajendra Chavan, thank you once again. Lots of wishes to Sneha ma'am. आप फटाफट आप वाइस प्रेसिडेंट बनो और let's continue this journey further.
Thank you.
Very good evening to all of you, and thank you all for being with us. Dr. Bharti
Thank you.
Maheshwari, आप हैं?
My
So
my
would like to-
society president is also there, Dr. Archana Rathod. So
Yes, please.
Sheila, are you here, Sheila?
Dr. Archana, a few words from you also, please.
No, I have been with Madam since 2004, and I have learned lot many things from Madam, and we are always there for Madam. And we are very proud of you, Madam, for being a part of Yavatmal OBGY Society.
Thank you, my dear. Thank you, Archana. So I just thank everybody once again, all the stalwarts of UPCOG and AMOGs, and I thank all my dear friends, esteemed panelists. Such knowledgeable panel I had today, and so experienced panel. So I thank. Initially, Rajendra sir, I have already welcomed you. Thank you. Personally, in the inauguration itself, you could not join, I think, but I thank you once again. Thank you so much.
So Dr. Kalpana, Dr. Neha, Dr. Amrita, Dr. Vidya Chaudhary, Dr. Neelam from Hapur. Thank you all.
Thank you, ma'am.
Thank you.
Thank you, ma'am, so much.
Good night.
Thank
Good
you.
night.
Thank you.
Thank you. Bye-bye.
And thank you, my dear. Thank you,
And
my
we
dear.
would like to we would like to continue the journey, madam,
Yes, definitely.
with
We
you.
will include you everywhere, and you will be the part of my team. Let us work together.
Yeah.
Thank you so much.
Thank you, ma'am.
With
Best
Vice
wishes.
President as Sneha.
Thank you, my dear. Thank you so much.
Thank you.
Thank you, ma'am. Goodbye. Goodbye.
Bye. Bye.
Goodbye. Bye bye.